Mohammed, would you mind helping me about how to bring the view to the screen? Hi, Steve.
Yeah, sure. Do you have any problem with the video or anything else? Because we have your voice and also your video very well now.
Okay, so how am I going to open how am I going to bring the screen to the Zoom?
Share screen. So you go to share screen in the bottom under all the people. Share screen. It's a green arrow up, pointing up.
Yeah, I did that.
Click it. Then you've got to go to highlight which of your screens you want to
managed.
share.
Okay, thank you.
Okay.
Thank you. I'm done.
Thank you very much. That's great. Could you please remove the the screen share now so we can start? And then, oh, that's great. Thank you very much, Professor.
Can I share the link with somebody in my department who wants to watch it?
Yeah, sure. We will be so happy. Thank you very much.
All right, thanks.
Thank you very much. Yeah.
Dr. Karamati, we are now on time. You can start.
Thank you very much. Yeah, sure. Hello, everybody, and welcome to this webinar. My name is I'm a colorectal surgeon and associate professor of colorectal surgery at Tehran University of Medical Sciences, Iran. And I have the great chance of being the moderator of this webinar. I have the great pleasure of welcoming you all to this international webinar on laparoscopic and minimally invasive approaches for colorectal cancers. This session is hosted by the Department and the Division of Colorectal Surgery, Imam Hospital at Tehran University. The department is a referral and tertiary referral of colorectal cancer cases from the whole country. This webinar has two parts. There will be 6 lectures that will be followed by a panel discussion. The panel is an educational panel. The lectures mostly cover various clinical topics on laparoscopic colorectal surgery, and the panel is an educational training of laparoscopic colorectal surgery for junior surgeons and also surgical residents. I'm delighted to briefly introduce our speakers. I will give a detail of each of the speakers later before their presentations. In order of their presentation, Professor Stephen Wexner from the United States, Professor Ibrahim Efem Geçim from Turkey, Professor Nuno Figueiredo from Portugal, Professor Willem Wemmerman from the Netherlands, Professor Amjad Parviz from the United Kingdom, and also my colleagues from Iran, Professor Amir Keshvari, Professor Mohammad Sadaf Bazali, Professor Mahdi Alam Rajabi, Professor Majid Samsami, Professor Ali Reza Kazameni, Professor Behnam Behboudi, Professor Mohsen Ahmadi, and also Professor Hamid Reza Zaman. I will give details about the lectures later. So if the speakers are ready, we can move to the first presentation. Professor Stephen Wexner. It's my great honor to introduce our first speaker, Professor Wexner. Professor Wexner is a professor of colorectal surgery, director of Digestive Disease Center, chair of the Department of Colorectal Surgery at Cleveland Clinic, Florida. He is also the vice chair of the American College of Surgeons. The title of his presentation is Rectal Cancer Outcomes According to Method of Access, Open or Minimally Invasive. Hello, Professor Wexner.
Hi, thanks very much for having me this morning. I greatly appreciate it, Professor Karamati. Great to be with you today. Sorry, I'm dressed for surgery. I've got to run off after my talk, but it's nice to share this time with you.
Thank you very much. I know that you are busy today and you will have an operation in half an hour. Thank you. We are all eager to hear your presentation.
Thank you. I'll get started with my presentation with sharing my screen, and what I'm going to be speaking about for the next 15 minutes is the current status of minimally invasive surgery, comparing the different technique. So if we think about a spectrum, on one side is open surgery, and on the other side is a completely transluminal operation with no abdominal wall incisions or punctures, and in between are the other therapies. I believe what is largely caught on around the world is a conversion from open surgery, hand-assisted, which is something kind of unique in certain practices in the United States, and we're not quite to note. So what we really focus on now are the various minimally invasive approaches of laparoscopy, robotic, and increasingly transanal total mesorectal excision. In the short time, we'll look at some of the data. I think starting with the classic trial, the original UK MRC trial group that David Jane and Pierre Gu headed. And in the 3-year follow-up, they found that there were no differences in long-term outcomes. So although initially they found higher circumferential resection margin positivity rates, it did not translate into an increase for local recurrence. And their conclusion was that the continued use of laparoscopy could be supported. The evidence started to get better with the Color 3 trial, and in the first publication, which was the short-term histopathologic assessment, what was found was actually an improvement. So the opposite of the classic trial. What was found is the circumferential resection margin in distal rectal cancers was less likely to be positive in laparoscopic than in open cases, finding an advantage for laparoscopy. And as time marched on, and the follow-up study was published in the New England Journal, these CRM positivity rates translated beautifully to local recurrence rates being roughly 1/3 in the laparoscopic as compared to the open group, disease-free survival not being significantly better, but disease-free stage 3 survival being significantly better. So less local recurrence and better survival with, or perhaps because of, lower rates of CRM positivity. And this, again, this type of conclusion kept us driving forward. Our results in the United States were tremendously flawed. Unfortunately, when we designed our ACOSOG Z6051 randomized controlled trial comparing open and laparoscopic approaches for patients with stage 2 and stage 3 rectal cancer, we tried to decrease the denominator of patients needed to ensure appropriate accrual. And in doing so, we created, with the statistician we used at the Mayo Clinic, we created a composite score. And this composite score had never been tested, had never been validated. And while we know that each of these variables independently is an important prognosticator, we have no idea what a composite score means. So none of these variables, although they don't look significant, none of them were powered sufficiently to say that there were no significant differences. The only thing powered was this composite score. And by the composite score, we found that laparoscopy was not equivalent to open. The same thing occurred in the Australasian study, not surprisingly, because the a la carte group asked us if they could use our composite endpoint, thinking down the road that a meta-analysis would be facilitated, would be much easier to compare various studies, apples to apples, rather than apples to pears. So they used the same endpoints we did. The problem is the endpoint was flawed. And so when we looked at the long-term follow-up in both of these studies, there's no difference in local recurrence, there's no difference in survival. So the composite end score, not the technology, was flawed. And in fact, what we found at Cleveland Clinic, Florida, was about a 25% improvement in lymph node yield with laparoscopy as compared to open. What about robotic? Obviously, the main focus of everyone's attention has been, again, David Jane, has been the ROLAR trial. And in this trial, in which 234 patients underwent laparoscopic, anterior section, and 237 open or anterior section or abdominal peritoneal resection, there were no differences in any of the variables here. So CRM positivity was the same, how an APR was performed was the same. There were absolutely no differences whatsoever. So the authors found laparoscopy and robotics to be equivalent. Neither one was superior to the other. It didn't seem to improve anything. So it's another method to approach the same problem. What about transanal total mesorectal excision? And this is where I want to focus because it really is the most up and coming technology. And when we look at the early results, smaller series of patients, we find very respectable rates of total mesorectal excision completeness and of tumor-free circumferential resection margins. A couple of studies started to get bigger. Antonio Lacey's study, in which I participated, the International Registry, and this other one by Minaya Bravo. Again, maintaining very laudable results and always hitting the number of lymph nodes or more. There's been some comparative studies. So this one, for example, not randomized controlled, but a propensity matched analysis, showed resection margin positivity to be higher in laparoscopic, but because the numbers were so small, there's no statistical significance. So all we conclude is it's equivalent. Specimen quality, comparing complete laparoscopic, complete TME, TATME, again, equivalent. The only thing that was different were conversions. That conversion rate, to me, seems exorbitantly high, 22%. I personally think a conversion rate in the hands of a skilled laparoscopic colorectal surgeon should be low single digits, but nonetheless, it is what it is, 22% versus none in the TATME group. And I think the reason is because of the ability to work from below, working up at the same time as working from up to down. The group led by Domenico Dugo, who the president of the European Society of Surgical Oncology, looked at, again, a propensity matched analysis. Again, still not a randomized controlled trial, but a propensity matched analysis. And basically found the same exact thing that had been previously identified, specifically that the conversion rate's much higher at almost the same number, interestingly, 19.6% as compared to 22%. And in both studies, finding a conversion rate of 0 with TATME. In addition, and I think this is one of the strong points of TATME, a longer distal margin. Why? Because it's under direct vision, as opposed to trying to put a finger or perhaps a rigid or flexible endoscope in the anus prior to stapler firing from above. Here you have the opportunity to look directly at the tumor and to very, very precisely place your distal purse string exactly where you want it. So you can know the exact number of millimeters of your margin. And I think that's why there's a 1 centimeter extra distal margin. Now, the point is, do you need it? Oncologically, not really. It's comforting, but whether you have a 15 millimeter, 25 millimeter margin, as we know from data from the 1980s, from Norman Williams' study, as well as from others, Phil Quirk and the like, it's not going to make a difference. So a recent meta-analysis and systematic review included 7 studies with 573 patients and found no differences in the number of lymph nodes harvested or positive resection margins, which is kind of surprising considering you're taking the distal margin under direct vision with the TATME. However, this just speaks to the technical prowess of the laparoscopic surgeons that they're able to achieve the same high rate of margin negativity. The TATME, as you look, not just the 2 studies I showed you, but through all the 7 studies, higher rate of complete TME, wider CRM, and very importantly, the authors found less positive circumferential resection margins with TATME. As time moved forward into 2019, again, similar findings. However, not everything is as optimistic. So I'm sure everybody's familiar with this BJS article, which was very, very sobering. Between this period of 3 years, between these 2 time points, 110 procedures were performed. Now, you have to think to yourself, 110 procedures in an entire country in 3 years translates to about 28 procedures per year, maybe 2 per month, give or take, spread out over the entire country. That's unfortunately not the way to build technical expertise, in my view, which may account for, again, in my opinion, an almost 10% local recurrence rate at a median of 11 months, and very nasty local recurrences, rapid and multifocal in the pelvis, leading the Norwegian health authorities to declare a moratorium on TATME. We were quite concerned with their finding and decided to very quickly audit our data. And Safo Rodbein, under the leadership of Roel Humpes, decided to query us, their center, and 4 other centers, where each center had done 100 or more at the one hospital, to get this number. With 6 centers, 767 patients. So the minimum, I think, was 100%er. And we found optimal oncologic outcome, 8% margin involvement. But very importantly, what we found was after median follow-up of over 2 years, our rate of actuarial cumulative local recurrence was 3%, not 9.5% after 11 months, as had been found in Norway. And in none of our over 700 patients was there multifocal local recurrence. We had 13 patients with isolated local recurrence, 10 of whom underwent successful salvage surgery, and 8 of those 10 were disease-free at the end of follow-up. So I personally think TATME is the best option out there, but it's not the only option out there. I mean, certainly laparoscopy and robotics are equivalent. We've shown that multiple times. I think avoiding open surgery for all the reasons we try to avoid open surgery is optimal, trying to avoid the morbidity of the incision, the prolonged ileus, the increased use of narcotics, the decrease in immune system function with more immune suppression, and on, and then more hernias and more adhesions later on. Clearly, I think minimally invasive is best, but not everybody can perform TME, TATME. So to perform TATME, we came up several years back with one of my alumni, Lisa McLemore at University of California, San Diego, and a few others, Patricia Silla, myself, others. The idea that you should have expertise in minimally invasive surgery and in TME with expertise in transanal endoscopic surgery, standard transanal endoscopic surgery for polyps and perhaps early cancers, experience an intrasphincteric dissection, and then practice, and then have your data collected by an ethics committee or institution review board approved database, and publish your outcomes as we've been doing, because this is the way to ensure success. This type of pathway will not be an option for every surgeon, because if you're in a place like Norway, where there's not a big population and you're spread out geographically over a huge landmass north to south, you may only see a few rectal cancers a year, and you won't be able to build your expertise. So that comes into sending to a referral center, as Antonio Quesido Marula and I worked on this article. So what happens when you go somewhere where you become the tertiary referral center, you may not even have a second colorectal surgeon. And then you need to do it by yourself. And it is indeed feasible. And Antonio and I and a few others worked out how you could do this thing by yourself. So I hope this is correctly spelled and worded, but I trusted one of my residents to put this together for me. I'm really happy to have had 15 minutes to share my thoughts and reflections on the various forms of minimally invasive surgery and open surgery for the treatment of rectal cancer with you. And again, I appreciate you inviting me to your meeting today. I wish it could have been in person. Maybe someday it will be.
Thank you very much for your great presentation, Professor Wexner. And also thank you for the Farsi slide. That was, great. Thank you very much for the slide. Yeah, so we are moving to the questions. I know that you are busy and you are going to have an operation. I cannot see any questions from here. Yeah,
I'll try and stay on to listen to the other lectures as long as I can. But
thank you very much. Now we don't have no question has been asked so far. So I have a question. If you want to select the patients for transanal TME, and you want to recommend, a junior, professor for doing that, What are the criteria that you recommend to that person?
Well, I think it's best to start out with a tumor that is not too low, because the very, very distal tumors can be exceptionally challenging. I also think it's best to start out with a fairly easy patient, one that, in other words, don't pick one that you think this is going to be impossible laparoscopically, so let me do a transanal to save an abdominal resection. So don't pick a BMI of 40 with a tumor 1 centimeter from the dentate line. Pick someone you could do laparoscopically and say, this is the first one I'm going to try. Obviously, after all the training steps we've outlined in those 2 articles, the one with Lisa McLemore and the one with Antonio Caicedo Marula, and start out with somebody that maybe is a female with a BMI of 25, that the tumor is at 7 centimeters or 6 centimeters, that you have a comfortable margin to be able to put your purse string under direct vision and work without fear of needing to do an intrasphincteric dissection. That would be my first case, and it should absolutely be proctored by whoever taught you the technique.
Oh, yeah, thank you. You mentioned the techniques hand-assisted. Do you recommend them now for any, any patient or no?
No, I never recommended hand-assisted. Personally, I didn't quite understand. I thought hand-assisted surgery was kind of like training wheels on a bicycle or crutches after you've had your cast removed from your leg, just while you're building your confidence. And then you get rid of the training wheels, or you get rid of the crutches. And that's in fact how it was originally designed. But then people kept using it. And I don't really see the point, to make a bigger incision, to put a hand in. I think either you do a laparotomy or laparoscopy, but that's my personal bias. I don't really, I've never used it. I don't really see a value in it.
Well, thank you very much. Thank you very much. Is there any, okay, there is a question in the chat box. Professor Rexner, what's your opinion about the urethral damage during TATME?
Yeah, I think the question is about the urethra rather than the ureter. And absolutely, it has been described, urethral damage during TATME. I think it's a matter of not understanding or not recognizing the planes. And this is why it is so important to go through the training pathway, as we've outlined, and to be proctored, as I've tried to emphasize, because you can easily get in the wrong plane. And it's important to be constantly conscious of it. Now, as we're progressing with our technology in fluorescence imaging, I am a big proponent of using near-infrared imaging to have things fluoresce. And if you inject indocyanine green in the catheter, or even around the catheter, periurethral injection of indocyanine green, fill the bladder. When you use the near-infrared imaging on your camera, you'll see the urethra light up. So I think that's another safety option. But again, it highlights why it's so important to be properly trained and to be in a setting where you can perform a high volume of these initially in a proctored approach. So this, at your center, your National Tertiary Referral Center in Tehran, that could be an ideal environment, versus a smaller hospital in a smaller city without a high volume would be in a situation like Norway again, where you might not necessarily be doing the best service to the patients.
Okay, thank you very much. Is there any other question from the participants?
There's one more question there. Do I recommend routine TATME in very obese patients with low rectal cancer? Yeah. Yes, I think I'm very fortunate that Dana Sands, who I sent to Gerhard Buis to train in in transanal endoscopic surgery, I don't know, 10 or 15 years ago, became one of our national and in fact international leaders in transanal endoscopic surgery. And sometime maybe 6 or 7 years ago, I brought her with me to Antonio Lacey, and we spent time developing TATME. She is the largest enroller of TATME patients in our US trial. She has a vast experience, and I like the fact that I can have her working down below while I'm working above in these obese patients. It definitely saves time. I think arguably it gives a much better dissection too under direct vision. However, I do not recommend it as a first patient. I do not recommend it as, the beginning of your learning curve. But as you've gained expertise, yeah, that's a great setting to use it.
Thank you very much. Other participants, if you raise hands, you can ask your question if you want, if there's any question. Okay. Thank you very much, Professor Rectal. Thank you for accepting our invitation and participating in this webinar. We appreciate you very much.
Thank you for your kindness.
Thank you. So we can move to the next speaker, Professor Geçin from Turkey. It's my great honor to introduce Professor Ibrahim Ethem Geçin as our second speaker. Professor Geçin is a professor of colorectal surgery at Ankara University Medical School. He has surgical training in Ankara and Royal Liverpool University Hospitals, United Kingdom, and colon and rectal surgical clinic. He is the pioneer of minimally invasive colorectal surgery in this country, and he has been the past president of the Turkish and the European Society of Colorectology. He will highlight the topic, transanal endoscopic treatment of early rectal cancers. Hello, Professor Geçin.
Hello, thank you very much for the kind invitation, and I'd like to salute all the people watching. And thank you very much again, you in person and the Tehran University for this kind invitation. The early stage rectal cancer,
yeah, thank you very much. We are all looking forward to.
Is this okay? That have a look. Okay, we go ahead. Okay, you okay?
Yeah, yeah, we are okay. We are ready. Thank you.
Okay, fine. Well, the early stage rectal cancer, when I say this, I mean the insider carcinomas, the invasive carcinomas, and the tubes.
Professor Geçin, you haven't shared your screen yet. We cannot see you.
Yeah, I haven't.
Your slides.
I'll do it again.
You have your voice and but. Oh yeah, yeah.
Is it okay now?
Thank you very much.
Okay.
Yeah, yeah, it's okay.
You're welcome. Good. Okay. Well, when I say early rectal cancer, I mean stage 1 plus the malignant polyps, and we have two options: the radical surgery, we do low anterior or the abdominoperineal excisions. These surgeries are having higher surgical risk. Probably they save the patient, but end up with a poor quality of life and poor outcome with the low anterior resection syndrome, and in many cases with permanent stoma. I'm going to talk about them one by one. But the local excision is actually having a lesser surgical risk, but probably carrying the risk of inadequate oncological safety. If it's successful, then the quality of life score is pretty high. So when I say inadequate cancer surgery, I mean positive margins and positive lymph nodes. So the patient selection and the surgical technique, especially not direct local excision, but the transanal microscopic surgery, endoscopic surgery is more valuable. So when you do radical surgery, the standard surgery, which contains total mesorectal excision, whatever the surgical technique you do, you have some perioperative mortality. There's no difference. The robotics or laparoscopy does not bring any improvement to the mortality you see at the end of rectal surgery. That's 1 to 5%, usually around 1-2% in the recent studies, but it may go up to 7%, for example. That's the German registry, which published in 2019, and goes to 7% in octogenarians in Germany. The complications are not rare. 1/3 of patients are having kind of complication or morbidity. It's also important. You have to postpone the chemotherapy, etc. And rehospitalization is also another important problem with radical standard rectal surgery. Stoma is a problem. So in permanent stoma, it is about 30% in the real life in all around the world. Well, the rates are seem to be a little lower, but even the complications occurred in the anastomosis or whatsoever ends up with a permanent or unclosable stomas in about 30% of cases. Once you have a permanent stoma, there are a lot of problems, starting from skin irritation, smell-related problems, bleeding from the stoma site, and appliance-related problems. For 78% of these patients having at least one of these complications related to stoma. After a successful radical surgery, even if everything goes okay, you manage to preserve the rectum, patient is just using the anus, you still have a problem, the nightmare called low anterior resection syndrome. So about 38% defecation and 39% urinary problems. Sexual problems are pretty frequent. We normally go after the male sexual problems, but if you question carefully the females, you can detect that they're having also a lot of sex-related problems. And finally, with those low quality of life scores, the depression ensues. So what transanal endoscopic microsurgery brings? You can reach up to 20 centimeters. The highest I reached is 18, 19 centimeters. I did a full thickness sigmoid resection with the malignant polyp, and I closed it with the stitches transanally without much problem. But the lower the lesion, the easier the manipulation. That's what I can say. You have a better rate of complete resection compared to colonoscopy. Certainly less morbidity compared to other surgeries, especially in the past. The transgluteal approach was trendy. People were just cutting off the sphincter, exposing the inside of the rectum by cutting the posterior rectal wall, and then getting the polyp out and then closing the rectum. So in the early days of my surgical life, I've experienced these, but these are so difficult surgeries, having a lot of complications afterward, like untreatable fistulas, and many of them were ending up with a stoma. So pathologists were very happy with it because you're not fragmentating the specimen. The specimen orientation for the pathologist is much easier, the ones who are harvested with the microsurgery, and it gives you a better pathology, a more accurate pathology report. Well, finally, the message is whatever you can do with the laparoscopy, you can do it inside the rectum with the transanal microsurgery. Certainly there are weak sides, so you have no idea about lymph nodes. You're just leaving them behind. They might be positive. Still risk of incomplete resection. You may have positive margins after careful removal. And tumor implantation, because you're splitting tumor cells inside the rectal lumen. And finally, when you suture it, there is a chance of implantation of the tumors, and the tumor may grow in the anastomosis line. Distant metastases is a problem, not only in transanal microsurgery, but also in any kind of local excision. I mean, even if after total mesorectal excision, you might have distant metastases in the early rectal cancer. It's usually 8 to 10%, but it may go up to 13%. This another recent paper shows 13% distant metastases after treatment of early rectal cancer. Fortunately, the local recurrence looks like a problem after transanal endoscopic microsurgery. See this is the local recurrence curve. The green is the local recurrence after total mesorectal excision, but the salvage surgery is effective, at least in this Dutch registry series, and finally the survival, 5-year survival, is not really shows any significance in difference. Both are coming to the same kind of 5-year survival. So I said the patient selection is very important. So the tumors favoring transanal endoscopic microsurgery is well differentiated, no lymphovascular invasion, no venous invasion, no tumor budding. These are all histopathological features. Also some genetic properties, which is a little bit early to talk about, but some genes, KRAS and BRAF, for example, presence of BRAF is a negative marker, but MMR mutations, etc. Maybe in the future we'll be selecting much better tumors to treat with transanal microsurgery, and the outcomes will be much safer by this. Getting back to the technique, it's first reported in 1984. This is Professor Gerhard Buss, which just passed away in a very early age with BISM. And after his original instrument, technique, several others developed, and now a robotic arm is being used at the moment in experiments. I don't know what the future is going to be, but looks like a single arm robotic instrument will be used inside the rectum, and we'll see if it's going to be any better effective or not, getting a better outcome. This is the instrument I use. This is a reusable one, economically much feasible. You just buy it once. Mine is about 7, 8 years old, and I didn't have any problem. Okay, you just fix it to the operation table with this rack. And there are 3 sizes of it. This is the small and this is the large one. There's one in the middle, depending on the height of the tumor. This is how it goes. These are irrigation and the gas tunnels, light source, and the camera head goes up to this ocular. Okay, let's see a case. Oh my God, yeah. Okay, this is an 80 years old lady, just didn't want to do abdominal surgery. This time I'm using a power device. I'm just buying some time. Okay, you see the white fat here, that's the mesorectum. Okay. Now, in this case, I prefer doing a single interrupted suture. This is better if the defect is too big, because occasionally, once you suture it with a continuous technique, then you may have narrowing in the lumen. I had problems like that. So putting interrupted sutures are safer that way. This is how it looks at the end. So I'm just giving a lot of irrigation to not implant any tumor cell. This is 3 months later. I scoped the patient 3 months later, then that's how it looks like. Patient is 87 years old now, completed 7 years and doing very well. This is a T2 case. I just scored out first. You don't have to be that wider, but you shouldn't be, the defect shouldn't be too big because you have difficulty to close it, and it shouldn't be too close to the tumor, just have to be adjusted under vision. This time I'm using a monopolar cautery. Okay, see, I'm just behind the rectal wall. Again, full thickness. It depends if you want to do a submucosal dissection, it is possible to do it. Unfortunately, you may not have a very regular resection borders. Sometimes it's very irregular and having some difficulty to suture it, but didn't have any problem to close it so far. Okay, this is a V-lock suture, so it's very easy. There's no tie in it. Once you close it, the defect is closed. Okay. Okay, now 3 months later, this is how it looks like. No problem, no sign of recurrence. I have about 60 cases now and having recurrent cases. So the higher the tumor T stage, so more likely to get recurrence. But for T1 tumors, I think that's going to be the first choice. And so why we bother and why don't we get it out with a colonoscopy? So this is the paper coming from American Gastroenterological Association. These are all experienced gastroenterologists, and they say the incomplete resection rate with the colonoscope is at least 10%. It may go up to 31%, depending on the type of the polyp, as well as the experience of the gastroenterologist. But incomplete resection is a big problem with the colonoscopy. So the other techniques, EST, EMD, etc., I think if the lesion is in the rectum, I prefer and I recommend doing endoscopic microsurgery rather than doing the thing with the colonoscope. So why don't we just go in, cut it off and put some stitches? Why don't we do transanal local excision and bother with all these instruments and using endoscopic microsurgery techniques? There are a lot of studies to compare it. This meta-analysis saying that 5.5% is the recurrence rate for benign adenomas. And when you do it transanally, the local recurrence rate is 23% in benign lesions. So if it's a T1 tumor, two things are compared. The height of it, the average height you reach with the transanal microsurgery technique is 8.2 centimeters, while with the direct surgery, you can reach 5.2 centimeters, and this difference is significant. As well as the local recurrence with T1 tumors, which is 5%, 5.5% with microsurgery, and with the direct surgery, it goes up to 14%. Again, it's a significant difference. So fragmentation and positive margins are it's a very classical information now. These three papers, Christoforidis now, we used to be residents at the same time in the state of Minnesota. He's in Italy now. So he studied the Minnesota cases, and the fragmentation rate was 0%. So you can take the specimen out with a significantly less positive margins. That's this paper from Peter Cataldo from Vermont. It's another classical paper of the area. With the transanal endoscopic microsurgery with T1 and T2 tumors, there's only 3% local recurrence rate, while it goes up to 26% with the transanal normal local excision. So these are the results. It's about 1 to 6% local recurrence rate with the simple benign adenomas. For T1 tumors, the overall 5-year survival rate is around 95%, while the local recurrence rate is 7 to 8%. And for T2 and probably T3 tumors, the survival goes down proportional to the stage, as well as the local recurrence rates goes up, again, proportional with the stage. Probably we got another minute or two. Another study has been carried out in several countries, but this is the American one. These are all T2 tumors, and they've been neoadjuvant treatment has been given to the patient first, and then a local excision with this transanal microsurgery has been done. This study was pretty hopeful when it started. It's about 10 years ago. The good part is about 45% of cases had complete pathological response, but the unacceptable chemoradiotherapy related toxicity was observed in 39% of patients. And staging is still a problem because some patients, after local excision, understood to be having T3 lesions. There were two options for it. Probably the tumor advanced during the radiotherapy, or it was T3 or T4 at the beginning and probably had some response to the chemoradiotherapy, but we never know that. So once you treat and then excise, means you never get the absolute correct pathology. With some percentage of cases, you always miss the pathological events. And thank you very much for your attention.
Thank you, Professor Gitchin. Thank you very much for your great talk and presentation. It's a matter of my interest as well, so I have some questions. But first, the questions from the participants. Any audience, any question? Professor Fazil, I can see your microphone is on.
Professor Jassim, thanks for your excellent lecture. Let me ask you a question. Do you request any MRI on other modalities, such as the EUS, before your local therapy or no?
Well, always. And a special MRI protocol, pelvic array, it's a special protocol to stage the rectal tumors, always done with the MRI. And also I'm using 3-dimension endorectal ultrasound. Not always, because MRI is given much more accurate staging compared to the endorectal ultrasound, which in our hands. And so we routinely do an MRI staging now. And if we have any doubts, we can always get the ultrasound to confirm the MRI findings.
Thank you. Any other question, Professor Fazeli?
Yeah. The next question. In a young man, 24 years old, with a villus adenoma in the rectum, 6 centimeters above the anal mesh. You perform the TUMS. The report of pathology is the well-differentiated adenocarcinoma with the involved margin. What is the next step? You recommend brachytherapy, radiotherapy, or re-excision or radical surgery?
Actually, I would involve the patient at this point for giving the right decision. Patient's choice is very important, and in most cases, the patients do not like radical surgery because it's a distal one. Apparently, the type of surgery should be a permanent stoma, should be offered to the patient. So in many cases, I have cases with post-resection chemoradiotherapy, and occasionally it works. But the best is to be aware of the tumor is invasive beyond the surgical borders and to get the chemoradiotherapy to be done beforehand, and then do a local excision or try more chemotherapy to given the consolidation treatment to get a higher complete pathologic response rate, and do no surgery if possible. These are all possibilities, but for the case which you incidentally find that the tumor is invasive, the surgical borders are also very important. I would go ahead and offer radical surgery for a young patient. So if the patient does not want a stoma or does not want radical surgery, maybe chemoradiotherapy is an option.
Thank you.
Thank you.
Dr. Wexner wants to say something.
Yeah, Professor Wexner.
Yeah, I have a question. Great lecture as always, my friend. I'm happy I got to hear it. Technical question for you. You mentioned the sort of single port robotic thing at the end, but short of that, in terms of the standard platforms, there's rigid and there's flexible. And I'm curious if you could comment on if there are roles for both types in different settings, or whether there's a preference for one or the other. There's at least 3 commercially available platforms. I'm just curious if you find a role for different ones in different settings, or you always use the same one, and if so, which one do you prefer?
Actually, for the economic reasons, I've traveled a lot. I've been to Netherlands. I've been to Eloy Espins Hospital in Barcelona. I've been to United States, watched at Boston Hospital. So eventually, the most feasible one for my setup is this reusable one, the stores one, because it's the cheapest. But we also have the applied reusable ones. I did a lot of cases with the SILS port, with the simple Covidian port. And our residents did some comparisons between the rigid stores one and the SILS port one. So the basic difference is the stores is giving you time advantage. We finish faster with this one. The SILS port works a little bit slower. It's difficult to handle all these things. So there's not much difference with the border positivity or the fragmentation of the specimen, etc. You can do it both ways. But there's a learning curve, and what you learn is your instrument as well. And there's another option now, the S port. That's I'm using a rigid one. Now you can put a plastic, how can I say? You can put the camera and you can move it much with a wider range. The instruments are more movable. I tried those, but I didn't have any technical difficulty in the last couple of years. Once you get used to it, it works in your hands, but it can be done with the others as well.
No, thanks very much. I think the point you make about economy and finances is an important one. Thank you.
Thank you very much. The questions in the chat area. You use 10 for T2 rectal tumors, as there is a 20% chance of lymph node metastasis in T2 tumors. What's your idea?
Couldn't get the question, sorry.
There's a question. There's a 20% chance of lymph node metastasis in T2 tumors. Transanal endoscopic microsurgery for T2 rectal tumors or not?
So do you know the lymph node metastases before you do the surgery, or did you find a positive lymph node incidentally after you do a local excision? Which one is the question?
Yeah, I think that as you mentioned, we need to do MRI before the operation to make sure there is no lymph node metastasis, and so it's not suitable for T2 also. Maybe it's okay for T1. I'm not sure. Is it right?
Okay. If I'm aware that there is a positive lymph nodes, I would not do a microsurgery or a local excision. With a positive lymph nodes, I would go for abdominal surgery. Nowadays, if there's only one or two, I mean, it's an N1 patient, and if the risk of violating the rectal fascia is not high, so apparently I can go ahead, do the surgery without doing any radiotherapy before. But if there is any risk of violating the rectal fascia, and if there is too much lymph nodes around, I would go ahead and give the radiotherapy first and then doing the surgery. But I'm trying to give less and less radiotherapy in the last 2-3 years.
Yeah, I see. Thank you. And another question from one of your, what measures do you recommend to prevent low anterior resection syndrome?
Okay. There's nothing much you can do, to be honest. I'm now working on a scoring system. The Danish group, the Aarhus group did a very nice scoring system, and later on it's just translated into several languages. And later on, last year, there's no new scoring system came about because in the old one, the patients were not involved in it. Now the patients are also involved. You're asking about the incontinence or the other dysfunctions, etc. But we actually did not know what is more important for the patient. So for the new approach to the scoring system for the functional things, the patients should get involved. And the new scoring system saying that the low anterior resection syndrome is actually a bigger problem than it is considered. I have patients saying to me, "Why did you save me? You know, having such filthy life, you know, put me in a very big difficulty." And you know, in the Muslim country, going to the mosque is very important. The Friday prayers, etc. So many patients are very concerned about it. A colleague of mine did a PhD thesis on it. Asked the patients who are having permanent stomas, so what bothers you the most? And 66% reported that being unable to go to mosque is the most important thing in Turkey. That's a scientific data. So trying to avoid permanent stoma, we are actually pushing very hard to preserve the anus, but finally we're getting more and more low anterior resection syndromes, and we can't really help it too much. But in the treatment phase, there is something new we tried. This tibial nerve stimulation is probably a hope. I've done a couple of batteries in the sacral nerves, and a couple of patients, I don't have big data to report at the moment, but I have some hopeful results coming with the sacral nerve stimulation. But again, for the first 2-3 years, until the patient accepts it and the patient trains himself, are going very difficult for the low anterior resection syndrome. I'm recommending loperamide, the bowel slower things, and I'm using psyllium, the cellulose powder to changing the stool. These may help, but these patients are never 100% happy with the low anterior syndrome.
Thank you very much. Another question from one of the panelists of this webinar as well, Dr. Professor Alam Rajavi. What's the role of TEM or TEMS in patients with complete radiologic and clinical response?
Say it again, please.
Yeah, sure. What's the role of TEM or TEMS in patients with complete radiologic or clinical?
I'm sorry, your talk is freezing, starting freezing. So what I understand is, what's the roles of TEM or TEMS in rectal physiology, impaired or what? So in general, with the rectal physiology.
Oh, no, it's not about the physiology. It's the role of TEM or TEMS in patients with complete pathologic and radiologic response after neoadjuvant chemoradiation.
Good question. Okay, I think there's no role on it. if you can, you are 100% sure that you have a complete clinical and pathological response, the TEM and TEMS only offers you a good biopsy of it. But unfortunately, the tumor heals very well in the mucosal side and in the rectal wall. So if it recurs from the lymph nodes and from the mesorectum. So taking a piece of rectal wall out does not really help you a lot. What you want to know is what's going on inside the mesorectum, what's going on in the lymphatics and lymph nodes and lymphatic tissue. So that's why once you experience a complete pathological response, the only way is to wait and see.
Okay, thank you very much. Thank you, Professor Geçim, and thanks for your time. And thanks for accepting our invitation and participating in this webinar.
Thank you very much, and I salute everybody from Turkey.
Thank you. So now we can move to the next presentation. Professor Figueiredo. I'm so delighted to introduce our third speaker, Professor Figueiredo is a professor of colorectal surgery and head of surgery at Hospital Ziadas, Lisbon, the University of Lisbon Faculty of Medicine. He's going to talk about laparoscopic total mesorectal excision. Hello, Professor Figueiredo.
Hello, good morning or good afternoon. It is really a pleasure. It is really a pleasure to be here. I am currently very honored, and I would like to thank you all for the kind invitation, especially Professor Karamati and all the organizing team. I'm currently trying to share my, okay.
Yeah, thank you very much. Yeah.
Thank you very much.
We are looking forward to your presentation.
Thank you very much. So the task that you asked me to present was, of course, trying to present you our technique of laparoscopic TME, which is a step-by-step approach. And of course, we cannot speak about TME if we do not involve at least a picture of our great mentor, Professor Richard Hill. Of course, at the end of the day, what we want, all of us, is to end our procedures having a specimen like this. It doesn't really matter if we do it laparoscopic, robotic, transanally, or even with more complex procedures that we're trying to figure out why. But at the end of the day, we need to present this to our pathologist and see a good result. And of course, this is not new. Getting these complex tasks into small modular, approachable processes is very old in nature. And of course, Mark Twain has already described a piece of information that I think it's very wise. And I think this is probably what has also inspired my other mentor, Professor Amjad Parvez, which I know is going to be one of the next speakers. Of course, I'm very honored to have in my background the learning experience of these two major personalities in colorectal surgery. Of course, following up on these steps, I think it's really important if we identify an index procedure and we cannot teach others if we cannot standardize and transfer this knowledge. Of course, we cannot assess and we cannot have quality control if we do not do standardized procedures, because at the end of the day, we want to have more of the same breed. Of course, if we go and approach just the laparoscopic TME, this is going to be a very reproducible procedure. We have patient positioning, we have the point exposure, we have, of course, vessel ligation, and then medialization. At the end, we need to approach the pelvis. And the pelvis, it can either be by a low anterior resection, either a PME, or even an ultra low with a TME, and of course, an extra levator or an intersphincteric or even a wider abdominal perineal excision. Nevertheless, we had the honor, of course, to participate in this publication from the LAPCO program, which is, many of you probably know, it was a national training program in the UK who tried to convert many of the open surgeons and train them into laparoscopic proficient colorectal surgeon. And this is what happened, as you can see, in the UK from 2004 and 5, which was around 10% of colorectal procedures done by laparoscopy, until 2012, the last publication, which is an almost 50% of the procedures. Starting up with the patient positioning, we need to inform and to report this to our colleagues, the anesthesiologists, because we need them to be very comfortable in doing sometimes extreme Trendelenburg positions in our patients. We do not use straps or other complex procedures of stabilization. What we use is a beanbag and simple vacuum-assisted immobilization. We use this setup and this configuration of the ports. We use an extra 5mm ports for low resections and for obese patients. We find it's very useful. And this is the team setup in the OR. So what is exactly the three-point exposure? Of course, the Trendelenburg and the right tilt, according to Professor Parves, and the transvascular exposure, followed up by the mesenteric root exposure. This is a very easy case on a slim patient, but this can be sometimes very cumbersome. The teaching point of this is we do not rush in starting the procedure if we do not have a very good mesenteric root exposure, because we'll get in trouble later on. Then, of course, vessel ligation and approach. We can either start by the IMV or the IMA. We tend to prefer to get on the back of the IMA and then progress upward. But of course, there are many techniques which approach first the IMV. No matter what, we tend to ligate the vessels with stable locks, locks or clips, and to cut the vessels with safety. Then, of course, we need to do, and we do it consistently, the splenic flexure mobilization. We don't want to do it in the end if we get a problem afterwards. So we usually tend to do it early when we are rested and the procedure is the beginning, because most of the time this is a very also cumbersome and troublesome part of the operation. Then finally, getting into the TME, we tend to approach the back of the TME because we find it easier to find the plane, like Professor Bilhild and also Professor Amjad always say, it's the yellow side of the white. So you can see it, you can dissect it. We tend to use monopolar cautery and monopolar energy at the beginning, especially because we find it's more easy to let the air in and do not seal the planes of dissection. Of course, it's a little bit more trouble and takes more time, but we find it pays off in the end. Then after developing the posterior plane, we go forward and we do the anterior plane. And this is a male patient, as you can see. We take our time, we open up the peritoneum, and we start by getting the air in. Then finally, we do the lateral mobilization and the lateral dissection. In this way, you can see almost a shape of the nerve because you have the back part and you have the anterior air coming in. So you can easily go and dissect the true plane, the true areolar plane between the lateral sidewall and the TME package. And finally, the left side, which is we tend to use it in the end. And then we progress and try to go further and further down on the pelvis, trying and taking our care to preserve the of course, the hypogastric nerves and the hypogastric plexus. Here you can see the upper part of the left side. And we take our time. We tend to use monopolar because it gets less dispersion. And then sometimes we find useful to stitch either the uterus or the bladder, especially the peritoneum of the bladder. And as you can see, we can easily get an extra port, or let me rephrase it, we can skip an extra port, hypogastric port, if we use this simple, very used trick of suspension. And it is very, very useful. So traction, counter traction, like Professor Bill Hill has said, and then we go further and further down the pelvis, trying to preserve the nerves. Here we can always decide if we have an anterior tumor, an anterior located tumor, we tend to go in front of the Denonvalier fascia, like you see here. If we have a side or a posteriorly located tumor, we can save the Denonvalier and we can cut it higher and we can spare most of the anterior nerves. Here we go and we approach the lower part of the pelvis, trying to preserve the neurovascular bundles, which tend to go inside and very adherent into the mesorectal package, but trying to preserve it in a way that we do not damage the lower hypogastric plexus. Again, the posterior completion is very, very important, because if we want to do a correct stapler and we want to do a stapling in 2 firings, we need to release the anococcygeal raphe. So the lower part, the last few 5 or 3 centimeters need to be completely removed. Otherwise, we can never do a cross stapling, a correct cross stapling with a linear stapler on the lower rectum. And we can go as low as the patient and our cameraman allows, but we can, in very slim patients, there's no problem in going even almost intrasphincterically. So what about transection and anastomosis? Well, this is always a tricky part. We tend to use the port, the lower left side port, and do this type of rotation. We introduce the linear stapler and we do a pronation of the wrist, trying to staple the rectum, the lower part of the rector, in an anterior to posterior fashion. And of course, hopefully, and most of the times we can do this, in 2 firings of 45 millimeter cartridges. As you can see here, we do not tend to tackle this in a one go. It's almost impossible in many of the patients to do this on a 45 millimeter cartridge and do it in a single part. And also, we need to account that the tissue will slide between the jaws and be pushed away. So we tend to do this always in a two stapler approach. And finally, trying to finalize this lecture, it's not only what you take out, but mostly what you leave behind, which is something my mentor, Professor Amjad Parvez, says many, many times. And finally, a quick note, it's very useful to test and to do the bubble tests with an endoscopy. It's an easy procedure. Most of the colorectal surgeons know how to do this. And this is very useful because for twice you control the mucosal, you can see how the mucosa is, you can test for hair leaks, and if there's a bleeding, if there's an arterial bleeding, you can always put a clip and control it and not find it in the next day. So final message is we need to do something, we need to keep it simple. We need to have a standardized approach. And if we are always changing our approach and our technique all the time, the nurses don't know what we are doing, our team doesn't know what we are doing, and of course, our pupils don't know what we are doing. We need to select one technique and try to be good at it. We need to perform correctly the lymph node dissection. And of course, we do not have to compromise oncologic results. If there's a problem with the laparoscopic approach, we need to choose another approach or even do it open. And finally, I hope all these constraints with the COVID, and we are getting a pretty bad hit here in Portugal. So we hope this all goes well in a very few months and to be open again for all of our colleagues that wish to visit us. So it is really a pleasure to be here and share with you what is our technique, and at least the technique that I've learned from my 2 masters. And I'm very happy to take questions and honored to be here. Thank you very much.
Thank you very much, Professor. It was a nice and informative presentation. In the chat area, there is no question. Is there any question from the participants? I have a question, Professor. What's the role of the additional 5mm ports in the right upper quadrant you showed in one of your slides?
Well, for two things. First of all, sometimes it's very useful in patients, in obese patients, once you need to have an extra retraction approaching the IMV in obese patients. The other sign we find useful is that we need to do, as you can see, we do most of our dissection with monopolar cautery, and we find useful to have a continuous traction, a macro retraction of the rectum. And in very heavy specimens, if you pull on the rectal sigmoid transition, or even on the sigmoid colon, and you can do it in a more lateral way, away from the field of vision, it helps the surgeon and the other assistant hand to perform a better job. At least this is what we think.
Oh, thank you. What's your opinion about retracting the sample out? What do you prefer, the lower abdomen incision, the midline small incision, or from the stoma side?
Well, it depends basically. So let me try to be concise in my answer. If we are going to do a robotic approach, we always start with a fine and steel, a transverse lower abdominal incision, because we keep the port there and we put the other ports away from the umbilicus. If we're doing a laparoscopic approach in a male, in a short patient, sometimes we find that opening up the umbilicus to extract the specimen gives a little bit more pain, and also it puts the stoma side, the ileostomy, very close to the large incisional extraction. So we prefer sometimes to do it in the lower abdominal part. So it really depends on the morphology of the patient. How much space do we have between our ports and our closure to put the ileostomy, which we do it consistently in irradiated patients and low rectal cancer. And of course, if we have patients that ask specifically, like female patients, we tend to do it more cosmetic incision like a small fine and steel incision.
Okay.
I have a question.
Oh yeah, I can hear some.
I have a question.
Hi, Professor Keshwari. Yes, sure, please.
Thank you, Nono, for your nice presentation. Good
Very,
job.
very nice to hear you. And I see many faces like Zamani here.
Yeah.
Nice to see all of you. Very, very honored. Thank you.
I like to know what is the benefit of ligature the inferior mesenteric vein. Is it any oncologic benefit for high ligation for IMV?
Well, very nice question. Thank you very much. Well, it's very interesting because, of course, oncologically, there's no issue. There's not an issue of oncologic benefit of ligating the IMV higher up. But as you might understand, and I had the pleasure of experiencing some procedures with Dr. Zamani and yourself here, and we understand that sometimes Asian patients and some Middle Eastern patients, you don't need so often to mobilize the splenic flexure and to get an extra length. So most of our procedures, we need, at least in the West, at least in Europe, we need to mobilize high the splenic flexure and always to ligate up. Otherwise, the mesocolon does not get down on the pelvis as nicely and as softly and with no tension as if we do not ligate. So it's basically a technical issue. It's not an oncological issue.
Thank you very much. Any other questions from the other participants? No, Dr. Zamani?
Yes, I have a question and my comments.
Oh yeah, I can hear the voice of Professor Alam Rajavi. Do you have any question or comment?
Yes, I write it in the message.
Okay. Yeah, you can ask your question.
I find out that the professor recommend endoscopy for. Thank you. I find out that the professor recommend endoscopy for checking the anastomosis. I have a question, and it is: do you do it routinely for all your procedures, and you check all the anastomosis by endoscopy at the end of the operation?
Yes, well, thank you for the question. Yes, the answer is yes. We do it routinely and we do it consistently in all rectal cancers. And we do it for two reasons, of course. We need to do, and of course, we have the availability of having an endoscope on the operating theaters. So it's very easy, it's very just bring it in. And of course, after firing the machine, we always like to check the mucosal color and the mucosal appearance of the anastomosis. We want to test the air test. We do it with the endoscopy. So we put, of course, the anastomosis under saline, and we do it the insufflation of under direct vision. And finally, because unfortunately in our, at least in my experience, I've found that sometimes the patient is very well, and the next day or in the afternoon, when the patient gets up in the chair, he starts getting bleeding and a lot of hematoma going down the anus. So if we have an arterial bleeding from the anastomosis, which is not that infrequent, then it's easy to put a clip, an endoscopic clip, and we don't have any unfortunate problems in the next day.
Sorry, and the next question, can we replace the role of indocyanine green with the endoscopy just after the operation?
Well, if you have it available, I think indocyanine green is just in the beginning of its use. I think we're going to find more and more evidence that we need to have all this technology helping us. Most of the times we use it because we have it available. I haven't found yet a case that without the indocyanine green, we have changed our approach in the meaning that, okay, we're going to decide and we do all the ligations before we define and we incise and we do the indocyanine green. And we have not yet found the case that we changed the approach. But I think it's an extra layer of safety. And if you have, if you record all your procedures like we do, we record it consistently, all the procedures. It's very useful to have a test that you can demonstrate that if you test viability for perfusion and you have a nice vascular supply of that part that you're going to anastomose. Unfortunately, the opposite appears, that we do endoscopy, we do indocyanine green, we do a very nice anastomosis with complete donuts, no tension, and unfortunately, we still have a number of anastomotic leaks. So I think if you have it, just cut it short. If you have it, you should use it. It's not a safety for 100% of the procedures, but it's another technology. And if you have it available, I think it's very useful.
Thank you very much. I can share you raising hands. Dr. Mancheri, hello, can you hear me? Dr. Mancheri, is there any question?
I have a question.
See.
Excuse me.
Yeah, sure.
Yeah.
Yeah, you can ask.
Thank you, Dr. Nuno, for your great presentation. It was very informative. I wanted to ask whether you ligate the artery and the vein before freeing the splenic fracture or after it?
Well, at least in the technique that I often use, which is the technique that I learned from Professor Amjad and Professor Bill Hill, we do it in a standardized way, like I said. Of course, I understand that many options exist. In my experience, what I do is I do the vessel approach first. So we either do IMA, IMV or IMV, IMA if we have a difficult IMA to approach. But we always do this before we tackle with the splenic flexure. Yeah, we find it useful because we go under the tent and we expose all the pancreas tail, and then we put a swab, and then we go from above and release the omental from the colon, and then release the final parts of the splenic flexure.
Yeah, thank you.
Thank you. Thank you, Dr. Ahmadi. Hello, Dr. Mancheri. If you want, you can talk. You know, your microphone is on, and we can hear you.
Excuse me. Excuse me. Do you routinely or always mobilize the splenic fracture, or you first evaluate the lens and then decide to mobilize the splenic fracture?
Thank you. Thank you very much for the question. I never do anastomosis.
Do you hear me?
Yes, yes. Can you hear me? Yeah. I never use a sigmoid to do the anastomosis. So I tend to prefer either left colon to sigmoid transition or even the left colon to perform the colorectal anastomosis or the coloanal anastomosis. So in doing that, in not using the sigmoid as a preferential part to do the colorectal anastomosis, you might understand that we consistently and systematically perform splenic flexure mobilization in every case. If it is a rectal cancer, a high rectum, middle rectum, or even, so even if we do a PME on a male, I never use the sigmoid, so I always resect the sigmoid, the rectum, the partial mesorectum, or the total mesorectal excision, and consistently do the splenic flexure mobilization in every patient.
Thank you very much.
Thank you. Thank you very much. Thank you, Diego. It was a nice presentation, and thanks.
Thank you very much. Thank you.
You're welcome. Okay, next presentation, Professor Bemerman. It's my great honor to introduce Professor Willem Bemerman. He is a professor of surgery, Academic Medical Center, University of Amsterdam, the Netherlands. He has also been the past president of the European Society of Coloproctology. The topic of this presentation is stepwise approach to transanal total mesorectal excision. Hello, Professor Bemerman. Professor Bemerman, can you hear my voice?
Okay, sorry. A common mistake. I was still muted. Do you hear me now?
Yeah. Thank you very much. Thanks for accepting our invitation.
Of course, and well, thanks so much for asking. So you asked me to address the stepwise approach to TATME, but yeah, we can speak about this a whole day. So I will try to squeeze all the essential parts into a 15 minutes lecture.
Thank you.
I will of course have to skip a lot of the scientific basis of TATME. So first of all, my disclosures, and I have to admit that since the end of 2014, the transanal approach is my favorite for mid and distal rectal cancers, for doing proctectomy and TAP pouch, pouch procedures in IBD, proctectomy in Crohn's disease. We approach leaking anastomosis with the TAP platform, doing redo anastomosis. We approach anastomotic vaginal fistulae, rectovaginal fistulae, and urethral rectal fistulae using this platform. And we manage our acute leaks with the platform using endosponge first and then primary closure of the anastomotic defect afterwards. And sometimes we need the TAP platform for that. So even if I'm an older surgeon, I consider myself already in the autumn of my career, I completely changed my practice at the end of 2014, applying the transanal approach. So coming back to the TATME for rectal cancer, we have to realize that, of course, there's an important laparoscopic part. Actually, we apply more or less the same technique as Nuno you showed us in the lecture before. We try to preserve the left colonic artery. We always take the inferior mesenteric vein, do a full mobilization of the left flexure, and use the proximal sigmoid or distal descending colon for the anastomosis. And we do the, let's say, the TME part essentially up to the levels of the vesicles. We prefer to do it in a two-team approach. So this is what the top-down team is doing, and the bottom-up team who is doing the transanal approach is involved in transection of the rectum after making the purse string, doing the TME dissection from the low and the mid rectum. And the TAP procedure is successful if we are able to do the rendezvous at the level of the vesicles in the man. Just to show you what we consider, to say what we consider as a successful transanal procedure if we are able to do a rendezvous at the level of the vesicles, because there the transanal approach has its advantage, not higher up, I think. So there's no role, in our opinion, to apply the transanal platform for partial mesorectal excisions, because there you can do a top-down dissection with a colorectal anastomosis. But we only do it for full TME. And the full TME is applied for the true rectal cancers. We know that recently the definition of rectal cancers has changed. So everything which is below the sigmoidal takeoff, that we call a rectal cancer, and that generally requires a full TME, which can be difficult, particularly in obese male with narrow pelvis. And if the tumor is very low, then there could be a problem saving the sphincters. There's more skill required there. There's a higher chance of having a positive circumferential margin. Most of the surgeons would divert these anastomosis because they're associated with high leak rates. So what is the problem? So what I said already, TATIMI is only indicated for the low rectal cancers, the true rectal cancers. The bottom-up view, if you start doing the transanal approach, causes anatomical disorientation because you're looking up instead of looking down. There are procedure-specific complications associated with TATIMI, urethra injury, bladder injury, pelvic sidewall injury with respect to the nerves and the urethra, CO2 emboli have been reported. And of course, we still have to await the oncologic outcomes from the big randomized trials like the COLOR3, and we have to appreciate a long learning curve. So if you want to take up a transanal approach, I think you really have to read the guidance that has come from the European Society of Coloproctology, which has been chaired by Roel Hompes and Dinelino Misuric. And there they state the indication for TATIMIs, what the surgical, how the surgical quality should be, how you should implement and train. So we think that you need an annual volume of true rectal cancers of around 30 in order to be able to set up such a program, structured training with 2 surgeons, and proctorship until a safe, independent performance. So, and of course, they state some definitions for expert centers on transanal approach. So if I would advise you, if you want to take this kind of surgery into your unit, if you have enough benign cases where the rectum has to come out, start with benign disease. So there you won't have any oncologic problem. Start in women, not too thin and not too fat patients. And if you address tumors, start with the small tumors, not too close to the anus and not anteriorly located. So you have to pick your patients. So don't start with the difficult patients who have a distal tumor close to the anorectal junction, tumors that are big with on MR a compromised circumferential margin. At the end of the learning curve, if you're a proficient transanal surgeon, these are the tumors who will benefit from a transanal approach. But of course, if you are still in your learning curve, you have to pick your patients in order to avoid damage to the patient and catastrophes. So the remarkable thing is that in the studies we did on this, particularly Roel Hompes, is that approaching these patients and looking at the circumferential margin positivity, that there are no patient-related factors which determine the rate of a positive circumferential margin. So the male sex and high BMI is not important anymore if you apply the transanal approach. So this shows the big power of this platform. So with respect to training, I would say, please go for a fellowship in a high volume center. It's all about surgical tactics and understanding anatomy. It looks a little bit like this in the beginning, but if you are more proficient, then you will see very quickly that this is the map of Europe. So these are the difficult steps of the transanal approach. So first of all, the setup of the platform, then making the purse string, washout after making the purse string, marking of the area where you want to do your rectotomy, a 360 degrees rectotomy, TME dissection, and then extraction and making the anastomosis. So what can go wrong if you have a bad purse string? It could lead to local recurrence rates because mucus can come out of the rectum, which is contaminated with tumor cells. I think that in the Norwegian series that this has been a problem, that they did not have a good solid purse string. If you're in the wrong plane doing your dissection, you can injure the urethra or the bladder. You can have pelvic side wall damage, bleeding and CO2 emboli. And if you perforate, of course, the specimen, then you can have tumor spill and local recurrence. In the end, we make a different kind of anastomosis, so not double stapling anastomosis, but a single stapling double purse string anastomosis, which is also quite new for most of the surgeons. And this can also lead to an increased rate of leaks in the beginning of the learning course. So first of all, the setup, we apply in generally a perianal block by injecting Kirokain on 3 and 9 o'clock parallel to the anus in order to make the sphincter relax. We use a Lone Star for exposure. We have the surgeon sitting on the left side in between the legs and the camera assistant on the right side. Camera is coming through this port. Then we have the air seal, which is very important for transanal surgery connected to the upper port, so that the cable is running through on the table, and a lower port for instruments. So, of course, during surgery, if you do your dissection, let's say posteriorly, you have to put your hook in the anteriorly located trocar and your grasper in the lower ones. And if you do your dissection anteriorly, then the hook is going in the lower port and the grasper for exposure in the upper port. So what is, if you start up with, you have to start up with the purse string. It's extremely important that you apply a good ball tension. This means that you have sometimes, you have to, what we normally do is that the top-down team closes off the proximal rectum with the band, so that if you insufflate, that not the whole bowel will insufflate, and then you can get a good wall tension in order to make a solid purse string. So you saw in the beginning that there was no wall tension, so that is not good, and so you need a good wall tension to make a good purse string. We use a monofilament 0, small equal steps. You can put in a gauze in the lumen in order to give better wall tension. You should not stitch too deep, because sometimes you take in your purse string tissues which will jeopardize your TME dissection. You need to make a circular purse string and not an oval-like purse string, and avoid bleeding in the wall. So then the step afterwards is a washout, and then the rectotomy. It's very important, again, that you have a proper wall tension for your rectotomy. And we always start posteriorly because posteriorly there are no essential structures which you can injure. If you go anteriorly in a woman, you can make a fistula to the vagina, or you can enter the prostate or the urethra. So always start posteriorly and do a full thickness rectotomy, because there's a great danger. So this is right, a full thickness, but there's a great danger that if you don't do a full thickness, you stay in the wall of the bowel, and then in the end, you will pass the purse string and will enter the tumor. So it's very important that you have good wall tension, and that it's quite clear that you enter in the mesorectum behind the bowel wall. So this is good on the left, good wall tension, and on the right you see that there's no good wall tension, which makes making the rectotomy much more difficult. You see that you have a sort of dissection in the wall of the rectum, and there's a big danger that you stay in the rectal wall entering the tumor. So you have to start posteriorly, because what I said before is that anteriorly you can enter the vital structures, and you have to look for the levator plate, and it's not a big problem to go behind the presacral fascia, but it could be a problem that if you are not posteriorly enough, that you already enter the mesorectum, damaging the distal part of the posterior mesorectum of the specimen, like is shown over here. Then, so if you don't go over the levator plate, it could be that you enter over here the mesorectum, which is not good. If it's possible, with respect to the location of the tumor and your purse string, is that you do your rectotomy beyond the level where you can injure the urethra. And we know that the urethra has a small part where it's very close to the rectum before it enters the prostate. And if your tube is very outside, because you have a very low purse string, and you're a little bit too anteriorly in the outside the rectotomy, you can injure over here the urethra. And so if it's possible, do your rectotomy at this level, then you're already beyond the place where you can injure the urethra. And so the rectotomy, not too close to the anus, if it's possible to avoid the urethra. So after the rectotomy, then in order to have a more secure purse string, here you see once again the complete rectotomy through all layers of the bowel. So if you have finished that, then you can make an additional suture over the existing purse string to have a more secure purse string. Because the worst thing which can happen is that during the dissection, there will be some mucus coming out of here. Here you see that in the back, we try to find as soon as possible the levator muscle over here, and then a little bit later, we stay anteriorly from the presacral fascia. That is very important. So we don't want to get into the mesorectum over here. So first find your levator muscle. So anteriorly, you already see here the prostate. So we already beyond the level of possible injury to the urethra. We use a V-lock to oversew the old purse string and to make a more secure closure of the rectum. Then finally, you can do an additional washout in the end before continuing with the section. So this is an interesting case because this actually, I think this was my second case back in 2014. You see that I was at that time lucky that I followed the levator plane very properly in the beginning. I still used the ultrascission, staying on the yellow side of the white very clearly. Here we already dissected a little bit the prostate, and fortunately at that time I realized that it is quite the tissue will ask you to get to in the wrong plane, but you have to stay on the yellow side of the white or the yellow side of the purple. Here we are anteriorly. You see that we split up the non-villous fascia, and how you can discriminate different layers in the non-villus. Here are the nerves which are dissected. And this is the non-villus over here, a little bit of ink of the marking of the tumor. And then here on the side wall, you see that the tissue is asking you to dissect over here, but that's wrong. You have to stay on the yellow side of the purple in this case, or the yellow side of the white, because the nerves, the plexus will run like this. So if you, the tissue asks you to go over here, but that's the wrong plane, you have to dissect over there. So, this was still at that time a one-team approach. So I proceeded as far as possible. This was in a male, and I was very lucky that the planes exposed themselves very clearly. So you will see in a minute that we, particularly posteriorly, we advanced quite high. Here you see that we make the rendezvous with Douglas. And I think the only injury we had in this area, we did not have urethra injuries, but I had once that the patient had a full bladder and that I entered the bladder, which was easily sutured, but that was in my learning curve. Here you see that this is the promontory, which is so that the dissection, we proceeded quite high. This is the hypoglossal nerve. And you see in the end, you see on the far side, you see the inferior mesenteric artery. So the only thing we had to do with respect to the TME part was taking the peritoneal attachments. But this is not what we do nowadays. What we do normally, if we work in a two-team approach, then the top-down team is doing this dissection up to the levels of the vesicles, making the rendezvous with the bottom-up team. So the rendezvous normally will be in this area. And what you will see in a minute, if we take out the specimen, that it has on his tip, it has it's like a block. So it's not tapering. So we do a complete mesorectal excision, not only posteriorly, but also particularly anteriorly. You see, if you take it out, it's like a block. It's not tapering. Yeah. So beware of bleeding, because if you find a bleeding, then you for sure are in the wrong plane. Anteriorly, that could be the prostate or the vagina, and posteriorly, of course, the presacral plexus. If you are in the prostate or in the vagina, there's danger of CO2 emboli. Realize that if you have a bleeding, it's a tangential vessel injury. So it's not, you didn't cut the vessel, only opened it on the side. So if you want to coagulate it, you should not coagulate over here, but on both sides to make the walls stick together. And if you cannot control it with diathermia, you have to use a gauze. So you and your anesthesiologist have to beware for the CO2 emboli, which will show if there's a fall in the end-tidal CO2 and a fall in O2 saturation, and if the patient is becoming hemodynamic unstable. So then you have to stop your insufflation. You have to, and then if you stop your insufflation, you will see that there's a bleeding. So you have to pack this and resuscitate the patient. And then afterwards, you might continue doing the procedure. So one more thing about the urethra injuries. I already told you that if you have to do your rectotomy quite distal, then the urethra is in danger over here before it enters the prostate. And it's quite apparent that sometimes the prostate is very loose and it's hanging as a ball down into your dissection area. And I show you that in a minute. Here you see a colleague of mine who let's say is outside his planes, because over here you see the muscle. It means that he's too lateral, he's too deep in, and this is the purse string. There's some tissue over here, and if you see two balls on top of each other, then you have to anticipate that the top ball is the prostate, which is hanging down. So they're looking for the right plane and dissecting, let's say, too high, because if this is the prostate, over here the urethra probably will run, and you will see in a bit that they will open the urethra and exposing the catheter which is there. Proceeding very carefully, but completely in the wrong plane, and so there you see the catheter, and then they realize that they are way too high, and then start dissecting below the top ball, finding the correct plane. And so here is the prostate. This is the level where the urethra is entering the prostate, and then the rectum is way down. So in a so here you see, I proceeded a little bit. So here you see the prostate, and there's the rectum, and the injury was over here. So if you're lost anteriorly, please take out the port and put in your finger, and mostly you will feel the prostate, and which guides you in the right plane. And if you're lost on the side walls, what you can do is that you pull on the specimen, and then you have a much better overview to understand the correct anatomy. So finally, of course, after the rendezvous and the top-down dissection, you have to make the double purse string anastomosis. So the anvil is sitting in the efferent colon loop, and you do your purse string on the distal rectum. What we mostly do is that we mobilize the edges of the distal rectum in order to facilitate doing a purse string. What we adapted last year is that we are doing not a purse string running over the wall of the bowel, but we go in and then we go back again, and we're in and back again. So in and out, not a running purse string over the edges, which makes closure of the purse string much easier than with the conventional purse string making. So to conclude, and these are a couple of general statements not related to the technique, but I think that TATIMI delivered in expert centers. We have to appreciate a considerable learning curve. There are many fantastic indications in benign disease. I think it's important to centralize low rectal cancer and the true rectal cancers. I think the upper rectal cancer and the rectosigmoid cancer can be done in most hospitals, but true low rectal cancer should be done in specialized centers. And those cancers are ideal for the transanal approach. Fellowship and proctoring, of course, is the key. And I would advise you to adhere to the ECP guidance paper. I thank you for your attention.
Thank you, Professor. To be honest, it was really interesting. Thank you for this great presentation. Question or comment from the participants? There is no question in the chat area, but from the participants, any question?
Well, it's good. I expanded a little bit talk was a little bit too long.
I think you explained everything about transanal TME, so everybody is ready to
Can
go
I
on.
ask a question?
Yeah. Dr. Ahmadi, yes.
Yeah, I thank you for your good and informing presentation. It was very enjoyable listening to it. I want to ask if you encounter bleeding in your operation, do you severe bleeding? Do you consider going from abdominal approach or trying to approach to it from the perineum?
Yeah, it really depends on in which level you are. If you're already close to the let's say the future rendezvous point, then what we typically would do is put a clamp on it. I think it's very important that you either put a gauze on it or a clamp to control it, and then proceed with the top-down dissection, take out the specimen, and then looking from bottom up and top down, control the bleeding. And if you have a bleeding, let's say quite early in a dissection, far away from the top-down dissection, so that the specimen is still there, then with suction and with gauzes and clamps, you might control it. And if nothing works, of course, just put in gauzes and proceed with the top-down dissection, and then control it from two sides if the specimen is out.
And one more question. From what I had seen in previous operations, because I don't do TME, sometimes I see the distal part when they want to purse it. It doesn't completely close for stapling. What do you advise for that situation?
You mean that the purse string is not closing? If you
the purse string is not closing.
It's quite typical that. So I think what changed our practice is that we mobilize a little bit the rectal cuff, so that it's not stuck to the pelvic floor anymore. And so that's one. And then the second thing is that we changed what I said in my last slide. We changed the way of doing the purse string. Normally, you go with your suture over the wall, let's say over the cut end of the rectotomy. And then it's sometimes very difficult to close the purse string. But if you go in the tissue, let's say on the mucosal side, and you exit on the serosal side, and then you go in again on the serosal side to the mucosa, and from mucosa again to the serosa, mucosa, then you don't have the suture running over the cut end, and it's much easier to close. And of course, you also should take a strong suture, so a 0. If you take a 2-0 and you want to knot that, and it's not running, it's not sliding good enough, then it might break.
Yeah, thank you very much.
Thank you. Yes, Professor Geçim.
Well,
I have a question.
Hi, William, and I'd like to thank you again that for the audience, we all learned how to do TME from William, and he just visited Ankara, and Ankara team at least very appreciating him very much for teaching us. I'm going to ask two questions. One is what you think about starting with TATA, the TATA. For the very low tumors, now my residents are not very, enthusiastic about doing TMEs, but they're very, very expert at how to do a TATA. They just cut the rectum from a very reasonable distance because they see the tumor under direct vision, and then they put a purse string, transect the rectum, and then bring it from up to down, down to up. They made a mixture, and then they do much better CRMs and much better distal margins. So I would like a comment about TATA, and I would like some few words about that Norwegian moratorium. I'm not very sure that it's a fair thing to write a moratorium, but stop doing it. Well, it's a very difficult thing. Maybe the training, the experting, and the learning curve should be standardized much better. But I'm not sure if everybody was ready to do TATMEs. It's a slow motion, though. I mean, we've been starting learning it for the last couple of years, and then very newly the technique is getting standardized. Have to be very patient and very slow to adopt it, and saying just stop, don't do it. It's a little bit too much for it. I would like William's comment on it. Thank you.
Yeah, well, first of all, Etim, always great to see you and really enjoyed being with you, particularly last time was fantastic. And to start with your second question, I completely agree with you. I think that the Norwegians, they started too fast and they all had low volumes, were not well enough trained. And yeah, and then yeah, trouble starts. With respect to your TATA, to be honest, before I started the TATME, I was not very enthusiastic about TATME. I thought, you know, I was quite happy with laparoscopic TMEs. And then yeah, sometimes you have patients with very low tumors, and then you do a TATA for the very low tumors. And so getting experience with TATA after a couple of these cases, and then having suddenly, I had to do a debate with Tim Rockwell about TATME. So then I thought, well, maybe I should take up TATME, but having the experience of TATA helped me a lot, starting with the TATME. So there's nothing wrong with doing, let's say, openly the first part of a TATME. If you can do that safe, then it's fantastic. And then maybe your young surgeons will proceed a little bit later if they have a lot of experience with this, with doing a TATME. Okay, they recognize the planes much easier coming with their experience with TATME, but you should not start TATME without having any transanal experience.
Okay.
I have a question.
Any other question? Professor Keshav?
I have
yes.
a question.
Yes, please.
Thank you, Professor Begelman, for a nice presentation. You told us that using TATME is possible for benign disease like Crohn. What is indication of TATME in Crohn disease?
The penetration. Well, in our unit, 100%. So actually all, and that doesn't mean other units, but we have a high caseload of benign disease. We do a lot of complication surgery dealing with pelvic sepsis. So the most distal part behind the prostate and the vagina in the pelvis are always approached transanally. So for Crohn's, if we have to take out the rectum, we normally would do an intersphincteric proctectomy in a TME fashion, because we believe that in Crohn's disease, the mesorectum is also inflamed. And if you do a closed bowel dissection in Crohn's disease, a closed rectal dissection in Crohn's disease, then you leave an inflamed mesorectum in situ, and you will end up with an abscess within the tube of the former mesorectum.
Thank you so much.
But I think it's a fantastic approach also for all difficult pathology in the distal pelvis. And of course, the great thing of benign indications is that there are no oncologic issues at stake.
Thank you very much. Any other question? I think that Professor Fazeli has a comment. Professor Fazeli, your microphone is up. We can see your
Professor
video.
Benelman,
Yeah.
thanks for your excellent lecture. As we know, you have a good experience in management of the anastomotic leakage. Possible ask a question in this?
Sorry?
Professor Fazeli wants to ask a question regarding the anastomosis.
Yeah.
Anastomotic.
Yeah. Do you have any experience with treating a presacral sinus other than the implanting of the endosponge, such as the brushing or destroying the sinus lining by APC? Have you any experience?
Yeah, well, the sinusotomy, which incorporates the presacral sinus with the neorectum, I think there could be an indication in benign disease. We know that from the Cleveland clinics, they apply that in chronic leaks in pouch surgery. But I think in patients who have a chronic sinus due to after TME for cancer, most of these patients had radiotherapy, and we have seen disastrous complications from a chronic sinus in a pelvis which had prior radiotherapy. Let's say the balance between infection and the resistance of the body is completely changed if the pelvis is radiated. And so in those patients, if you do a sinusotomy, the chronic inflammation in the radiated presacral sinus can still protrude alongside the peripheral muscles and give rise to infections of the upper leg. And we have seen disastrous long-term complications of pelvic sepsis in the radiated pelvis. So I think, yes, the sinusotomy for benign disease, you can try that as a first step. And for the chronic leaks, for the acute leaks, we apply endosponge, but no for patients who have a sinus after a TME with preoperative radiotherapy.
Okay, thank you. Next question. If possible, tell us about your experience about the management of the stenosis after the rectal cancer surgery, especially low and ultra low anastomosis, both the incidence, causes, and the modality, for example, dilation and stenting, if possible.
Yeah, you mean
about your experience?
The anastomotic stenosis after, we do not defunction after a TME in our practice. So the anastomosis is immediately used. So we know at day 4 whether they leak or not. And if they don't leak, they will, I haven't seen any stenosis in my practice because immediately the anastomosis is dilated due to the bowel, the stool who's coming out. And of course, if they do leak, we defunction these patients and use endosponge and repair the leak within 2 weeks, which also prevents the stenosis. So we very rarely see stenosis as a late complication. We do see, of course, leakages and chronic sinuses, but stenosis is very rare. So I don't have much experience in treating stenosis. I'm sorry.
No, I ask you.
Yeah.
No. Thank you very much.
Thank you very much, Professor Benelman. It was interesting. Thanks a lot.
You're
And
welcome.
thank you very much for accepting our invitation. We are so happy to have you here.
Okay, have a great afternoon and rest of the meeting. I have to continue with an operation.
Yeah, sure. Thank you very much. Goodbye.
Bye-bye.
Goodbye.
Bye-bye, Ethan.
Okay, moving to the next presentation. I'm not sure if Professor Amjad is here or not. I cannot see his name in the list. Professor Amjad, can you hear my voice? He told me that he will join us. Okay, anyway, we can move to the next presentation by Professor Keshvari, and then we will back to Professor Amjad. Professor Keshvari, are you ready for the presentation? Professor Keshvari?
Yes, I'm ready.
Okay, great. I'm so happy to introduce Professor Amir Keshvari as the next speaker. Professor Keshvari is a professor of colorectal surgery at Imam Hospital, Tehran University of Medical Sciences. He is interested in minimal invasive approaches of surgery. His talk is management and endoscopic follow-up of pelvic anastomotic disruption. Hi, Professor Keshvari. Thank you very much for accepting our invitation, and we are all looking forward to hearing your presentation.
Hi there. I'm talking about management and endoscopic follow-up of pelvic anastomosis disruption. Is there any problem for my video?
I think that Professor Beverman needs to close his screen sharing, as we can just try to share your desktop.
I don't share.
You can't?
Sorry.
Oh, I can see the last slide of Professor Beverman now. Okay. Oh, great, great. We can see your slides.
Are you seeing my slide?
Yeah. We can see that. Thank you very much. We are ready.
Okay. As you know, pelvic anastomotic disruption include all colorectal and colonal anastomosis for rectal cancer surgery, and also for ileal pouch in ulcerative colitis and polyposis. Let me start with this photo. As you know, this is a circular anastomosis in a rectal cancer. There is a large hole here. It is around 25% of this circular anastomosis. What is the best name for this? Maybe name it anastomotic leakage or para-anastomotic sinus or perisacral sinus or perisacral tract. Anyway, it is pelvic anastomotic disruption. Reported incidences of symptomatic leakage of colorectal and colonal anastomosis is around 9 to 15%. This is endoscopic view of one of our patients 3 weeks after low anterior resection. As you see, there is a large hole here full of fibrin material and debris. We evaluate inside the hole by endoscope. What are risk factors for this complication? Preoperative radiotherapy and distal tumor location, especially when it is lesser than 3 centimeters, is too known factors that significantly related to disruption of anastomosis. Many studies introduce smoking and obesity as two other factors for disruption of anastomosis. Also, high pressure sphincter, especially in young men, is a risk factor. Some surgeons believe perisacral dead space that we create after TME maybe have some part in disruption of anastomosis. How about a stapler type? Is it a matter? Significantly, it is not a risk factor, but in our experience, we have many problems with some brands of stapler. Also, how about anastomotic type? Is it a matter? I mean end-to-end or end-to-side anastomosis. Is any difference? The studies show no any difference about anastomotic type. Some surgeons believe releasing a sphenic flexure of colon by decreasing tension on anastomotic side maybe have some part in risk factors as a disruption of anastomosis, but it is not proven yet. In one multicenter cross-sectional study, LAR anastomotic leakage was diagnosed 13.4% within 30 days. But if we wait more, maybe this rate increased to 20% beyond 30 days. As you see in this diagram, maybe some leakage maybe happened 2 or 3 years after anastomosis. What are early signs and symptoms for anastomotic disruption? Some of these patients are asymptomatic. When we are trying to examine them before closing the ileostomy, we find in endoscopy or dye study that the anastomosis is disrupted, and it is so late. Some of these patients have minimal symptoms like weakness, like lack of appetite, and most of them have transanal discharge, low back pain, and rectal bleeding. How can we diagnose the disruption? Rising sedimentation rate and elevating CRP maybe help us to diagnose. A cutoff point of 134 at 4 days after operation is important number. Contrast enema maybe help us. CT scan, especially triple contrast CT scan and MRI maybe help us. The best diagnostic tools is sigmoidoscopy, especially when done by the same surgeon, because I believe surgeons are more familiar than GI mans to endoscopic view of anastomotic disruption. When pelvic anastomotic disruption not healed at 12 months, it maybe result in a chronic perisacral sinus. In one study, they showed 48% of pelvic leakage not healed at 12 months. In that report, the rate of chronic perisacral sinus in all of their case after LAR was 9.5%. And unfortunately, near half of these patients, they haven't any chance to reverse the stoma anytime. If perisacral sinus remain more than 1 year, maybe some secondary complications occur, like perisacral pain, anemia, purulent discharge. Maybe unusual fistula formate. We have one fistula from the cavity to upper part of sacrum in one of our patients. Hydronephrosis related to periurethric fibrosis reported, osteomyelitis, necrotizing fasciitis, and malignant transformation also reported in perisacral sinus. How can we manage this disaster? At the first step, we have to divert the bowel if it is not done so far. We have to washing, cleaning, and doing debridement and draining that cavity. Maybe we have chance to anastomotic redo operation in that time, but mostly it is not possible. Maybe we have to doing an abdominal colostomy and postpone the anastomosis for a later time. How about other ways? Are there any options? There is a list here that reported previously that may be possible to doing for anastomotic disruption. Preanal colostomy and early anastomosis, injecting, closing the anastomotic defect transanally, inject the fibrin glue after curettage, remove the sinus to rescue the anastomosis, and endosponge treatment. This is a photo from one of our patients who was a 47 years old male who was diabetic. We find 1 week after LAR, a complete disruption of anastomosis. We take the proximal part of the bowel out and waiting for some days to demarking the proximal part and resecting ischemic part, and transanally we do a redo anastomosis. Fortunately, 12 months later, this patient have success to an uneventful ileostomy reversal. And this is another of our patient. This is the continuity of the bowel and it is side of defect in anastomosis. We close this defect transanally by simple suture, and injecting the fibrin glue after curettage also reported as a way for overcoming this problem. I have not personally any experience about this way, but there is a report with success in all of 7 patients followed for a 11 months. Remove the sinus to rescue the anastomosis. The first report is from 1997. They do transanally and using rectoscope, cutting the wall between the pouch and the sinus, and making a way for getting out discharge of the sinus. Maybe we can remove the sinus by using TUMS. There is a case here. This lady has a leakage in blind part of her pouch. The surgeon cutting the wall between these 2 holes by endostapler and making enough space for doing any work. He cut the leakage site and cleaning it, curating inside the cavity, and then simply close the defect by suture. and draining it outside. Endosponge treatment is another way. We have some experience with this way. We make endosponge by hand among operation with a simple sponge and a hemovac drain. We suture it over the tube. Firstly, we measure the size of the cavity, and with the size of we make the sponge with size of the cavity, and insert the sponge inside the cavity by hand and drain it. It is like a dressing of infected abdominal wound infection, and maybe after some time help to cleaning the cavity of disruption. We repeatedly change the endosponge every 2 up to 5 days. We change the endosponge. All material, debris, and hematoma and every foreign bodies may be collected inside the hemovac bag. You can see in this photo that losing slappers are sticking to the sponge, and after sometimes gradually the whole cavity of the disruption maybe would be a smaller size, and even maybe healed spontaneously without any suture. Let me show you the outcome of some of our patients that treated and healed the cavity just with this simple endosponge. Now this man, the first endosponge we insert for him 3 weeks after LAR. 2 months after LAR and after 5 times endosponge replacement. This is endoscopic video. You can see inside the cavity. This anastomosis was a side to end anastomosis. This is a benign loop of anastomosis. And you can see the proximal bowel here. We continue to change the endosponge 5 months after LAR and after 13 times endosponge. In this video, you can see we are trying to getting out the sponge from the cavity. You see inside the cavity is clean and more smaller than previous one. The orifice of the sinus is so large, but unfortunately there is no any stricture in proximal bowel. 12 months after LAR, this is another endoscopic view. You can see the cavity is completely healed. There is no any sign of the cavity and no any stricture. Proximal part of the bowel is clean, no any pus, and fortunately 14 months after LAR, we do an ileostomy reversal, and patient is fine so far, but have some mild symptoms of LAR syndrome. This is another one of our patients. These patients have not any symptoms. 3 weeks after LAR, we do an rectosigmoidoscopy just as checkup. This is endoscopic view. We evaluate inside the cavity and length of it. This cavity is maybe 4 or 6 centimeters, and we make a proper endosponge for this size. 2 months after LAR and after another endosponge and 1 unsuccessful repair, we do another endoscopic video. You can see the suture of unsuccessful repair. There is sinus tract over there. It is not so clean and need to more endosponge replacement. The same patient after 5 months of LAR and after another endosponge, and we leave him 3 months free from any procedure, and then we do another endoscopy. You can see the cavity is completely healed. There is just a stitch granulation tissue here, but there is no any stricture. It is not so problem. Unfortunately, 8 months after LAR, we closed his ileostomy. The next, our patient was some challenging because she was a lady. After 8 times endosponge replacement, her cavity healed, but partially with some stricture. 5 months after LAR, this is her endoscopy. There is a cavity over there, but there is a stricture. We are trying to overcoming this stricture. We push the anastomosis side. Eventually, we have success to passing the stricture at anastomotic side. Because there was not any killing cavity over there, we have to continue to replacement of endosponge after some other endosponge replacement, and 10 months after LAR. This is endoscopy video. The cavity is closed, but we have an important problem because the way of the bowel is so narrow. We was not assured if we closed her ileostomy, she will have good defecation. We intermittently doing 5 balloon dilatation, and eventually after getting consent from herself and her family, 18 months after LAR, we reversed her ileostomy uneventfully. She is fine so far, but have moderate symptoms of LAR syndrome. Okay, what is our recommendations? Take-home messages are no trust to ileostomy. It's delayed diagnosis of leakage. No leave perisacral sinus for spontaneous healing because it may not be healed and maybe occur some severe complications. We should try to early detection of asymptomatic leakage, especially before 30 days. We should start to treatment at early phase. It has shown that chronic sinus is less frequent if we start to treat in early phase. It is significantly different. Be aware of late symptoms of leakage, and endosponge treatment is effective for spontaneous healing of sinus. Endosponge treatment can protect severe complications. Thank you for your attention.
Thank you, Professor Keshvari. Thank you very much for this great presentation. There is a question in that area. How frequently do you change the sponge?
Okay, every 2 or 3 days or 4 days, according to the condition of the patient and the material that extract from the sinus, we change the endosponge. Sometimes we hospitalize the patient, or maybe patient go home and come to us for just a outpatient procedure, and we do a anesthesia, simple anesthesia, and changing the sponge.
So on a weekly basis, you change the sponge?
Yes, maybe if the cavity is clean, weekly change is also possible.
Okay, that's great. Another question in the chat area. Most of the patients, after management of anastomotic leakage, have a serious pelvic without any abscess cavity or osteomyelitis. What's your opinion about the management of this group of patients?
I couldn't catch the question.
In a group of patients, we don't have any leakage, even any sort of abscess or cavity or sinuses, okay, but they have just pain.
Yes.
And
if the patient have
group of patients?
If the patient have just pain.
Yeah, without any leakage or sinuses.
How you document sinus? Maybe we should have a document by rectal sigmoidoscopy or MRI or CT scan. If there is no any sign in the DIA study or MRI, and also in rectal sigmoidoscopy, this pain may be not related to leakage. If leakage was happened, we can find in endoscopic view or MRI or CT scan.
Okay, great. So you believe that mainly it goes back to a problem in the pelvis. Okay, another question by Dr. Mancheri. Dr. Mancheri, you can ask your question here. We cannot see your picture.
Professor, for your late.
Dr. Mancheri, we cannot hear your voice.
I started.
I think there is a problem with your.
Yeah, I started.
Oh, that's.
Excuse me. Does the CRP level rises in late anastomosis leakage? Your voice.
Sorry, I didn't got questions. It's very bad. Please.
Excuse me.
Yeah, please tell it again.
Excuse me. Does the CRP level rises in the late anastomosis leakages too?
Okay, so
because I've had 2 patients that, yeah, does the CRP level rises in the late low anterior anastomosis leakages and sinuses? Because I had 2 patients. I first checked the CRP level to see if it's over 135, and they didn't had it. But when I examined the site with the rectal sigmoid, I saw that there is a leakage and sinus formation.
It is possible for every anastomosis in distal or proximal part of anastomosis. This is a cutoff point, but there are some other studies that introducing more than 135 as a cutoff point. I'm not sure. Maybe is it possible without rising CRP or not? But all of our patients have disruption of anastomotic with more than 135. I think in our experience, it is an important number.
Excuse me. Late anastomosis leakages too?
What is your means about late anastomosis? Is it you means
about
after
1 month after the operation, the index operation?
No, most of late anastomotic disruption, because we have some patients after 8 months or one patient after 3 years. The symptoms of these patients was rectorrhea, and the CRP in this patient was not elevated.
Thank you very much. Another question. During the leakage, when we see there is a disruption and patient is under the chemotherapy, do we are obliged to stop the chemotherapy sessions?
I think
should we stop the chemotherapy sessions, or we begin the endosponge insertion sessions and continue chemotherapy sessions too?
I think it is better than chemotherapy not stop, and because healing of the cavity maybe need to more time, and if we start chemotherapy in later time, the patient have not any benefit from the chemotherapy. We should not postpone the chemotherapy for treatment of the cavity.
Okay, thank you very much.
Thank you so much.
Thank you very much, Professor Keshvari. I just Professor Amjad has joined us since 4 o'clock today, and with I didn't notice him. Hello, Professor Amjad. We are so happy to have you here for the next presentation. Is Professor Amjad Parviz. He's a professor of surgery at the University of Portsmouth, the United Kingdom, director of the European Academy of Robotic Colorectal Surgery, head of colorectal surgery, Champollion Foundation, Lisbon, and consultant colorectal surgeon at University Hospital Dorset, Poole, UK. He is also the head at Hamad General Hospital, Doha, Qatar. His interest is teaching has led him to develop teaching programs for numerous countries, including Iran. He will hold the subject on minimally invasive approach to transverse colon cancers. Hello, Professor.
Salam, everyone. Thank you very much. Thank you.
Sorry for this inconvenience. We didn't know that you're among the participants. Thank you very much.
No. I have a very common name and a very common face. I get lost very easily. Don't worry.
Yeah, thank you very much for your patience. We are eagerly looking forward to hear your presentation. Thank you.
Okay, well, first of all, thank you for having me, and thank you for all my friends. It's very nice to see very familiar faces after such a long time and seeing them well and safe is a very good news. So salam to everyone. Topic that you have given me is transverse colon cancer. And this is important topic for different reasons, for cancer oncology outcome, as well as the technical approach to transverse colon, because of the complex anatomy that sits at the root of the transverse mesocolon. So I would just spend next 10-15 minutes speaking to you about something that you might already know, but just to sort of share with you a few points about the transverse colon cancer. This talk really would speak about just the demographics of the colon cancer in the transverse area. I would just briefly focus on anatomy of transverse colon, although having said that, nobody does this better than our friend and colleague from Ankara, Professor Ayhan Kuzu. If you ever had a chance to watch him demonstrate his cadaveric dissection, I think they are priceless masterclasses to attend. Anatomical location of the tumor in the transverse colon and impact it has on the choice of operation, transverse colectomy versus extended right, for example, or extended right hemicolectomy versus segmental left resection for splenic flexure tumor. So these are the individual choices that surgeons have to make based on the location of the tumor as well as the patient factors. I would just share a few slides about the data on a very recent publication around these choice of procedures too. So why this is relevant? 10% of all colorectal cancer, they exist within the transverse colon. And the transverse colon, a true transverse colon, lies between both flexure, hepatic flexure and splenic flexure, anatomically speaking. The presentation within this site is often delayed. It is not very uncommon to diagnose these patients with palpable abdominal mass or a fistula between the stomach itself or small bowel involving the tumor. So a significant proportion, up to a third of these patients would present as a fistulating or obstructing disease. Distal transverse colon or close to splenic flexure tumor often stitching in nature. We all have seen emergency presentation of large bowel obstruction with a very tiny lesion at the splenic flexure, which is almost occluding the lumen of the bowel. Given that they present late, given they present with complex localized problem, it is not uncommon to see their presentation as a locally advanced tumor in clinical practice. So about 20 to 40%, depending upon what series you would read, would relate these as T4 tumor. And interestingly, globally speaking, the 5-year survival figures globally, I'm not talking of expert centers with high volume and good outcome. Obviously, people have shown better survival, but overall, the prognosis for transverse colon cancer is generally not very good when you compare it to sigmoid colon, for example. So what are the useful points before embarking on surgery? I think localization of the tumor is hugely important. Now I'm talking within the context of minimally invasive surgery. So you have lost the tactile or the palpable feedback. You're relying on your laparoscopic instrument or robotic instrument, and that doesn't have any tactile feedback. So you're relying on visual clue. So it is important that your tumor is seen on endoscopy, is seen on a CT scan as well, at the same correlation between the two sides. I have had experience of going for a splenic flexure tumor and at operation finding it at hepatic flexure. And I'm sure it's very easy to mix both of these flexure depending upon the anatomy of the colon of individual patient and the skill of the endoscopist. So if my CT scan in MDT cannot locate the tumor, then I insist on doing colonoscopy myself and then inking 5 centimeter distal to the tumor. But if the CT scan can localize it, then ink perhaps become less important, because one of the downside of doing a tattooing is that if you go through the bowel, then you would see ink spread into the peritoneal cavity, which is not very good, obviously intraoperatively. Some specialized centers in complex cases often take advantage of radiology colleague to make 3D reconstruction of vasculature or the arterial supply of the transverse colon when they do central venous ligation for mid-transverse tumor, for example. So it is not routinely used, but used sparingly depending upon the expertise available and the radiology colleague willingness to help you in difficult, sticky positions. Now, I could have used any diagram, and there are individual variation. I'm not going to spend awful lot of time boring you with one variation after another, but this is, in ideal word, you would want a superior mesenteric artery to give you ileocolic vessel in about 17 to 15 to 30%, depending upon whichever series you read, you are likely to find a right colic artery. And then there is a middle colic artery that comes off superior mesenteric artery, and they divide into right branch and left branch. And it's very obvious to see, even in the diagrammatic way, how these branches interrelate to each other. So in central ligation concept, you are going at the root of the major vessels. You know, this become important in terms of localization of the tumor. So for example, a tumor in the ascending or hepatic flexure, you don't need to go on the other side of the middle colic, for example. This is just an example to use. This area holds the clue in my mind, the retroperitoneal relationship of the transverse mesocolon, which is duodenum on the right side, and the body of the pancreas and the tail of the pancreas on the left side, and the stomach and the superior aspect hold the clue for the anatomy. And I think as a surgeon, we all need to be aware in three-dimensional view in our head where those structures are when we embark on minimally invasive approach. Arteries are not so much of a problem because when they bleed with pulsatile flow and you can easily sort of control them. The bigger problem is these fellows here, which are blue. And this is what I allude to. Superior mesenteric vein that gives off ileocolic or ileocolic vein draining into this. If you have a right colic vein, you would see it. Then you have GCT trunk as well coming up to here, middle colic vein going up and dividing into right and left branches corresponding with the artery. So most people anatomically, when they do central venous ligation or central ligation of the vessel, they follow the line of superior mesenteric vein as a surrogate marker of where their radical dissection would be at the root of the vessel. So instead of remembering the name of everything that comes out of the right side, most people would say take ileocolic and any branch that comes to the right of the vein all the way up. This is what I meant by duodenum, and then the pancreas that sits in the front of this running along this direction. This is a hugely important anatomical structure when you mobilize flexure, hepatic as well as splenic flexure. This is just reiterating. These are the pictures borrowed from Dr. Ali, who works with us here in acute care. He very thankfully lended these slides for me to be used. So I'm grateful to him. But you could see this is where the problem is. The problem is the central location of the major clockwork, because for cancer section to happen, you have to go at the root of these vessels, and that's become a problem. Lymph node yield, this is a revisited space. You know, people already know about this, that taking radical lymph node dissection, and there are in the literature D3 and D2 lymph node dissection, whether they have a higher lymph node yield, whether they have an impact on survival. This is a debate which is still going on. And currently there is a trial running from Alexei Karachun unit in St. Petersburg called COLD study, looking at D2 versus D3 dissections. But the bottom line is this, that you need to take the vessel at the root, do all the lymphadenectomy to come as a part of the specimen. And I think this is the key to remember when you do oncology surgery. So first of all, this is the obvious debate, you know, why we should do an extended right hemicolectomy for a proximal transverse colon or mid-transverse colon. Why can't we just do a transverse colectomy at its own? You know, there is a debate from 1960s and 70s. And while preparing this lecture, I had an interest reading with some historical papers. People have published very good outcomes when they, in 1970s even, when they were doing open transverse colectomies when comparing it to extended right hemicolectomy. This is a similar paper. This is not very old. As I sort of said, this is 2018, World Journal of Surgery, optimal treatment comparing a laparoscopic approach, either doing laparoscopic transverse colectomy or doing laparoscopic extended right hemicolectomy for a mid-transverse colon. So in both cases, the middle colic artery was going. And they showed that lap approach and laparocolectomy have similar oncological outcome. Laparoscopic extended right hemicolectomy might be associated with fewer postoperative complications because you are joining small bowel to colon, which may have better blood supply and perhaps have less morbidity associated with sepsis and leakage. This is what the study demonstrated. Now, this was just the one center giving their opinion. This is a Danish study coming from Denmark. They looked at oncological outcome. If you remember the history of transverse colon tumor and laparoscopy, and I would remember this because I was a trainee in 1990s when the classic trial was being run in UK. And transverse colon tumor were often, they were excluded from classic trial because of the technical difficulties the surgeon might face. So even in those times, people were aware that this is potentially a challenging area to approach. And in Denmark and in Norwegian countries, by and large, they were very slow to adopt laparoscopy for transverse colon location of the tumor. They did it for sigmoid, they did it for right hemis and for rectum, and the transverse colon came way at the end. So this is a nationwide study for 3 years or 4 years, 2010 to 2013. They were looking at laparoscopic approach and open approach to say that is it feasible, is it safe, and is it oncologically at par with open technique. And they showed that although associated with low rate of mesocolic resection plane and fewer lymph node, so laparoscopic approach had less number of lymph node when they compared it with their open group, but they had similar long-term results in terms of survival and loco-regional recurrences. So this was no surprise, but it took them a while to sort of come to this. When you look at move from center to country, and now you move to European-wide consensus, this is a splenic flexure cancer study group. Lots of eminent name on this paper. We looked at extended right hemicolectomy, left hemicolectomy, and segmental left hemicolectomy as the 3 operative modalities, and to look at the outcome. And they showed that when you adopt this approach, the present study support the resection of splenic flexure cancer by colon sparing surgical techniques such as segmental laparoscopic colectomy is equally good. So this is not a newer notion, but there's a data coming through that for truly splenic flexure tumor, rather than doing a big extended right, you can do a segmental left resection with a high tie of left colic artery and left branch of middle colic artery and omentectomy as a part of the specimen. And you can achieve similar outcomes, short-term as well as long-term. So this is very new. This is ahead of the print 2021 in surgical endoscopy. So then they looked at, is segmental resection, it could be an alternative for splenic flexure cancer. This is another study published a couple of years ago, no surprises. They said that this is possible to achieve similar outcome when you do a segmental resection for splenic flexure tumor. We looked at our own data. This is our own paper from Portsmouth many years ago. We looked at short and long-term outcome for splenic flexure tumor, which were either treated by extended right or segmental left colectomy. And we showed that there was no difference both in short-term and long-term outcome when we compared both techniques. The only observation from our practice and study is that if patient present as an emergency, we were likely to do an extended right hemicolectomy, and in elective setting, we chose to do segmental left colectomy for splenic flexure tumor or distal transverse colon tumor. The problem is the standardization of the operative technique, and I think that's where most of us fall down. So for example, when you have to take a segmental resection for the splenic flexure or distal transverse colon tumor, you have to mobilize splenic flexure on the basis of oncology. And I said pancreas hold the key when you mobilize the splenic flexure. So just to sort of let it run as it is running now, I do artery first, come at the top of the pancreas, and then I can break above the pancreas into the lesser sac. You could see the back of the stomach as a surrogate marker. The key really here is once you have made the window is to not to climb up rather than to stay at the upper border of the pancreas to do oncology, as well as to take all the lymphatic tissue that sits here. So pancreas hold the key when you're mobilizing the flexure. Other important thing to remember is that I don't divide the vein until I see the pancreas and either I have gone in or at least the gauze have gone above it. Because if I divide the vein here, before I go here, this small bowel in some patient become a real pain and it follows you underneath here and it makes it very difficult to see things. So I try to keep the vein as long as possible. Again, to put it on the side, and then just making the window going step by step, bigger and bigger at the top of the pancreas, doing all the lymphadenectomy. Once you go toward the tail of this, then you come laterally, do the lateral mobilization up to the splenic flexure, mobilizing the left colon, and then put the patient head up. Then obviously I divide the vein at that stage, make the patient go head up. And here in this case, because this is a transverse colon tumor, all the momentum has to come with us. You put the patient head up, and then you start just close to the stomach, trying to get into the lesser sac, where you would find it here. So once you've seen the lesser sac, now you're going to stick right just outside the stomach wall, taking care not to burn the stomach wall. Ask your assistant to push the colon downward as you follow this aperture. And I'm looking for a gauze that I put in the window from below, because remember, I have gone through this. And there is the gauze here that is protecting this. And then I see this. And then the idea is to follow the shape of the colon, because the straight angle would always take you toward the spleen. So always follow the shape of the bowel so you can just join the two. If you have done all of that from below and to the left side, then literally this is 4 or 5 burns to mobilize this completely. This is a very standardized way of how I mobilize splenic flexure for either TME or for cancer. The difference obviously is with TME, I leave the momentum attached to the stomach. So this is a very structured, standardized way of doing it. This is perhaps, I don't know whether this would play or not. This is another patient. You could see this is a slightly biggish guy. Again, done everything the same way. Come from below, taken the vein, gone into the window. This is the pancreas, the whole body of the pancreas sitting there, all the mesocolon attached to the specimen that is going to come in. So it's very important to have a very structured and standardized way. Now, the left segmental colectomy, this is a recent case we did for a splenic flexure cancer. Here you don't have to sacrifice inferior mesenteric artery. This is done robotically. The steps are pretty much the same. You start medial to lateral, come up, see the bifurcation of the IMA is here, and you can see bifurcating and going up as a left colic, segment branches, and then going as a superior rectal artery. Isolate all of this, and then selectively just clip the left colic at the origin as a high tie, which would be the main feeding vessel for the splenic flexure mobilization or the splenic flexure tumor in this case. Once you've done the bottom part, then you have to come and take the left branch of the middle colic, and you have to take it at the origin for oncology, obviously, and that reference come from the pancreas. Remember, this is another big guy, a splenic flexure tumor we did recently, a locally aggressive distal transverse colon tumor actually. And this is a segmental colectomy done for him. We have done the bottom part, which is the left branch of which is the left colic artery as a high tie below. And now we are trying to go at the root of the left branch of the middle colic. And that will only come from exposing the pancreas and mobilizing the splenic flexure completely before you actually approach this. So I approach this vessel as a last step. You could just about see the window. He's a big guy. BMI was I think sort of close to 40, biggish guy, young guy. But again, the principle of the surgery stays the same. So, you see the vessel just at the top of the pancreas. You could see this is the pancreas distal to it. You would just see it as the vessel become obvious. There. The clue is that you have a complete access of lesser sac. Don't go with no access into the lesser sac, because then you can get your hands wrong and your head wrong around it. So once you've isolated it clean, and then you can clip it. I mean, a lot of people use energy source. I try to clip the vessel if I can name them. You can just see it on the right side, similar sort of thing, a gold hemlock clip, 2 below, 1 above, and divided. So this is a very standardized way of doing a high tie for left branch of the middle colic. Now, how do you approach middle colic? Middle colic approach for me is very simple. I have taken ileocolic vessel. I have taken right branch of right colic if it is there. Drop the pancreas, drop the duodenum, mobilize subileal, mobilize the hepatic flexure. Then I go and I mobilize the splenic flexure and get into the lesser sac above the pancreas. So you could see it here now, So you're almost standing at that stage between the legs, because I have patient in modified Lloyd-Davis position, and I stand between the leg of the patient with screen facing me. And then I have this V of the mesocolon, of the transverse colon, and I move from one side to another, making this smaller and smaller until I see one vessel to take. So this is just to give you an example. I do it. If you are doing it for benign disease like an ulcerative colitis patient, you don't obviously need to be at the root, but for cancer, you have to be at the origin of the vessels. This is approaching middle colic now. You can see the cut edge on the right side of the picture is here, which is, this is back of the stomach we are looking at. You could just, I think I'm just talking to fellows. This is the pancreas. You're sitting at the top of the pancreas, back of the stomach, and you're following it back now. So you see it as a single vessel. Occasionally, you get 2 branches of middle colic coming side by side. I have seen this once or twice, but I don't get disrupted with this. I usually sort of take it as a single vessel coming in. Also, important thing for doing middle colic is to make sure that you don't have too much traction. In a slim woman in particular, you can pull the superior rectal artery up, mistaking it as a middle colic artery, which is a catastrophe. So that's why I always say, make pancreas horizontally as your landmark, and take the vessel right at the root. You can see the pancreas is right at the back here. And I've just taken the artery, 2 clips, the part which is staying in, and then you go in and you do that. In the end, once you have gone and done everything else, this is a good picture of the whole specimen showing you here. So here is the main feeding vessel, as you could see it. I just stop this. So you can see that once you have divided it, disconnected it from below, you should be seeing the whole of ileocolic, right colic, and the 2 clips in the middle colic. So it is the same structured, standardized approach that you have to take and to demonstrate. And this is important as well. You could see the clips right in the middle for the cancer. I don't know whether this would play. This is someone else doing the same SMV, ileocolic, right colic, and then the middle colic in the middle. Stomach is there, and whole of the pancreas sitting clean, all the momentum taken as a part of the cancer resection. So location of transverse colon cancer and the choice of operative procedure is an important consideration. So, I mean, this is my current practice. This is not the final word, as it were, but if it's a hepatic flexure cancer that I'm dealing with, then I would do what I call a standardized right hemicolectomy, which would mean taking ileocolic vessel, a right colic vessel if it's there, or the right branch of the middle colic centrally, and do an anastomosis. If I have a proximal transverse colon tumor or the mid transverse colon tumor, then I would do an extended right hemicolectomy. That would include all those vessels plus the middle colic artery. Then I take the middle colic and I go on the other side, the falciform ligament. If I have a tumor in distal transverse or the splenic flexure in elective setting, then I do a segmental left resection as a choice. And in an obese patient, I prefer to do intracorporeal anastomosis because it makes it that much easy. So in conclusion, I think the survival remained poor, which is a biology really, nothing else to do with surgeons, but obviously poor surgical technique contribute toward this. MIS or minimally invasive surgery, either done robotically or laparoscopically, have shown this to be safe for short-term and better short-term outcome, same oncological long-term outcome when you compare to good open surgery. It's very important to have patient by patient approach, surgical approach, depending upon the location of the tumor, rather than just sort of saying, I do extended right in everybody, or I do a transverse colectomy or a left colectomy. So you need to have the approach based on individual patients. I genuinely believe that two things hold the key in most things in surgery. Anatomy obviously dictates what we end up doing, and teaching and training would bridge the skill gap and take this fear away from the surgeons, because we as a colorectal surgeon only go with what we are familiar with. I'm very grateful for having the patience to sit there this late in the evening and listening to me. If you have any question, I'm happy to take it. Thank you very much.
Thank you, Professor Amjad. Really great talk and informative. I know that approaching transverse colon is the most tricky and also, difficult part of a colon resection, laparoscopic colon resection. Thank you very much. Any question from the audience? There's no clarifier in the chat area, but any question from the audience?
I have a question, Dr. Karamati.
Professor Amjad, please.
First, thank you. Salam. Hello,
Salam.
Professor Amjad.
Hi.
Nice to meet you.
Nice to see you too.
Thank you very much. What's the role of total colectomy in patients with cancer in transverse colon?
When you say total colectomy, you mean removing all the colon for a solitary tumor in the transverse?
Yes.
We don't. I mean, I personally have not done that. Usually, people we have considered doing a total colectomy are young people with multiple tumor or attenuated FAP patients. But a solitary tumor, our MDT have never recommended unless there is a genetic problem. So if you have more than one tumor location, including transverse colon tumor, then you might consider it, but not a solitary tumor. When you give this choice to patients, most people would like to keep their colon.
Okay.
Thank you.
But I think that total colectomy is good for patients that we cannot do anastomosis very well for them. Do you agree with me?
No, I think what I'm doing is this. So which would be those patients? So, for example, when you say total colectomy, you are asking subtotal colectomy and either ileorectal or endileostomy. Is that what you're asking?
No, ileorectal anastomosis.
Yeah. So I think I would not do that procedure purely on the basis of this is easier anastomosis. I would only do that procedure if indicated by tumor, and the age. For example, if there are multiple foci of tumor in the colon, then you might consider that approach. And then you can have the individual discussion of whether you should join them or you give them endileostomy. That's a different debate altogether. But not for the convenience. I would not do this as a convenience.
Thank you very much.
Thank you. There is a comment from Professor Geçim. Yes, please.
Actually, not a comment, but a question. I was doing more and more extended right hemicolectomies, and my residents, actually, well, my colleagues are more inclined to do right hemicolectomies. But I personally, after several years, considering the late outcome on the function of the bowel,
Yes.
I now try to preserve ileocecal wall as much as I can.
Yeah.
So I'm more inclined to do splenic flexion mobilization and keep the resection as left as possible. And I believe, I don't have any data, but it's a sense and belief. I think physiologically, left-sided resections for transverse colon tumors comes up with a better functional outcome. Would you comment on it, Amjad? By the way, I'm going to pass your good comments to Ayhan Kuzu. He'll be happy to hear that.
Yeah. No, that's correct, actually. You know, when I was young, like you mentioned, most of us learned this in the era of doing an emergency open extended right, you know, as registrars. And you become familiar with it, and everybody teaches you that this is a safe anastomosis. You are doing ileum to colon and everything else. But as you sort of grow older, you have elective practice, and then you start seeing these patients in outpatients and ask them the functional question, which you alluded to. As a registrar, I never had any problem because I never saw them. You know, the boss used to see them. But as a consultant, they all come back to you. You are absolutely right. If an old woman, you end up sacrificing all her right colon and going her almost like ileo subtotal, she would have a terrible function, you know, in terms of quality of life. So in elective practice, increasingly for the last 14 years at least, if it's a distal transverse or a splenic flexure tumor, we prefer to do a segmental left, because that would give them better function. We know we don't do suboptimal oncological job, so we don't have oncological failure because we are doing a bad job oncologically, but functionally they do benefit.
Thank you.
There's a question from one of the participants. Do you recommend total omentectomy or partial omentectomy for a tumor?
Yeah, it's a good question. And I think you could argue either way. When you talk to Himberger, he would say total colectomy, because total omentectomy. They would just stay outside the stomach arcade and remove everything. I do partial omentectomy depending upon the location of the tumor. So if your tumor is distal transfer or splenic flexure, all the omentum on the left side would go as a part of the specimen. There is no point removing the hepatic flexure omentum, you know, oncologically speaking. So that's my practice. I know some people would say remove whole of the omentum, but I think that practice is more with gynae tumors, where they're after the total omentectomy. The colorectal tumor behaves slightly differently than gynae tumor. A partial omentectomy does the job oncologically as well.
Okay, thank you very much. Another question in the chat area. If there is a benign lesion, like in proximal or distal colon, with a transverse colon cancer, what's your idea?
So if there is a benign lesion
in
on
the
right side,
or distal colon,
yeah,
in addition to
a transverse colon tumor.
Yeah.
Yeah. Okay. So the deal breaker is how good is your endoscopist. So if they can take that benign lesion off with an EMR procedure, then you don't have to do big radical resection. Sometimes you have your arm twisted because these guys would tell you there's a big flat lesion in cecum, we can't take it out endoscopically. Then you're doing it more for convenience rather than for oncological need. So I try if there is a lesion distal to the cancer, then and it looks benign, it feels benign, and they can endoscopically take it out. I prefer that they do not remove it before the cancer operation, because there's a risk, there is a downseed seedling risk. If you remove the polyp under the tumor, then the cancer cell might migrate and get seated there. So you do the resection and they can remove that polyp in the next 6 months within the surgery.
Okay. Thank you very much. Another question again in the chat area. Is it mandatory to close after right hemicolectomy or not?
Mandatory to close mesentery defect.
To close the mesenteric defect.
Yeah, no, I have never done that. I know there is a theoretical risk of small bowel hernia or small bowel obstruction. I personally think that that when the defect is larger, people don't become symptomatic, even if they have an anatomical problem of small bowel going through the gap. So I don't close it in my practice.
Okay. Thank you very much, Professor Amjad. There is no other one. Any other question from the participants? No. No. Thank you very much, Professor.
Thank you. Thank you for having me.
Thank you very much. I really appreciate it. Next presentations will cover an educational topic, integrating laparoscopic colorectal cancer training into general surgical residency program. We have some presentations in this section and also a debate regarding the presentation. In this section, Professor Mohammad Sadegh Fazeli, Head of the Division of Colorectal Surgery, Imam Hospital, Tehran University of Medical Sciences, Professor Mahdi Alam Rajabi, Colorectal Surgeon, Associate Professor of Colorectal Surgery, from Iran University of Medical Sciences, Professor Majid Samsami, Assistant Professor of Colorectal Surgery from Shahid Danish Beheshti University, Prof. Hamid Reza Zamani from Nikon Hospital, Prof. Behnam Behboudi, Assistant Professor of Surgery from Tehran University, and also my colleague, Prof. Mohsen Ahmadi from Tehran University of Medical Sciences will join us in this section. I want to ask Professor Alam Rajabi to start his presentation in this section. Are we ready?
Yes, I'm ready.
Oh, thank you very much.
Is it okay?
Yes. Yeah.
Okay. It's my honor to be here with you, professors, and my friends, and especially thanks Mohammad Reza, my friend, to invite me.
You're welcome.
Thank you. I'm not a specialist in education, but I did my best to prepare these slides to do slides for education of laparoscopy and laparoscopy in colorectal surgeries in Iran. Sorry, my slides.
We can see your slides. It's okay.
But I cannot change them. Yeah. Do you see? Sorry.
Sorry, Professor. Can you full screen your slides?
Sorry.
You can use arrow keys in the keyboard, but if you change it,
which buttons?
If you make your slide presentation as a full screen, at the bottom of the screen there is a slideshow.
Sorry.
Dr. Alam Rajabi, we have we can move to.
Sorry.
Is it if it's okay? If you have a problem, that's okay. We can move to.
No. I think it's okay. And how can I turn back to
so share screen
Zoom?
So if you do share screen at the bottom of it, do you have a share screen option?
I guess you already full screen your slides, and because of that, you cannot see the window of the Zoom.
Yes.
So put the escape and click the escape button. So you go off from the full screen mode, and then you can
Okay.
see the window of the Zoom.
Yes.
And again, share it, and whenever you share it, you can full screen your slide.
After share it.
Yes, yes.
So I share my screen.
Yes,
Yeah.
now we can see, yeah, and full screen it.
Is it okay?
Yes, it is
I think
okay.
we can proceed. Yeah.
Thank you. Thank you. Sorry.
You're welcome.
In Iranian Ministry of Health curriculum for training of general surgeons, presence of an adjunct colorectal ward and essential equipment of laparoscopic operations are emphasized. In our hospital, Firuzgar Hospital in Tehran, we have more than 25 cases of colorectal cancer surgeries monthly, and 18% of them are performed laparoscopically. All the elective surgeries are performed by an attending physician and 2 fellowships. And the residents will also have the opportunity to be involved in all urgent, emergent, or elective cases, as this is an integral part of the subspecialty. The first question, does resident involvement in laparoscopic colorectal surgery cases negatively impact outcomes and ultimately increase costs? This is the study, this is an article in 2014, and the aim of this study is to determine if resident involvement in a large cohort of laparoscopic colorectal surgery cases negatively impacts outcomes and ultimately increases costs. Resident participation in laparoscopic colorectal surgery does not affect overall mortality or morbidity. But it may negatively impact hospital costs through increased operative time and length of hospital stay. So early and intensive laparoscopic training may be necessary for improving residents' laparoscopy skills before their involvement in laparoscopic colorectal surgery. Do you have my slides?
Yes.
But I think that I cannot change them again. Yeah.
You have your slides. It's your slide on, the resident participation.
Yeah, but I cannot change it again. I don't know why.
So if you can click,
okay.
Yes.
Okay. Okay. Prior to performing advanced laparoscopic procedure, the resident must be familiar with and experienced in basic laparoscopic skills. Such skills are best acquired in skill laboratories using surgical trainers, animal models, virtual reality trainers, or other stimulated operating conditions before the trainee confirms these procedures in the operating room on patients. Examples of such skills include two-handed instrument manipulation, dissection, intraoperative suturing, and intra and extracorporal knot tying. Laparoscopic procedures, as with all operations, should be learned in the broad context of surgical science and practice. Critical educational components include the pathophysiology of disease, diagnosis, operative operative indications and contraindications, alternative treatments, comprehensive principles of pre and post-operative care, and understanding the prevention, diagnosis, and treatment of complications. In addition, surgical residents must be familiar with the advantages and disadvantages of both open and minimal access approaches. SAGE's long-term goal is to continue to facilitate the complete integration of advanced laparoscopic training within each surgical program. Residents should ultimately master these procedures in the operating room under the direction of a skilled faculty instructors. Until such time as complete integration is possible, SAGES believes the following measures can help accomplish this goal. Train faculty, train residents, and provide guidelines for post-residency training for prospective faculty. The other question, how many operations are needed? Learning curves for laparoscopic colectomy are reported in the range of 20 to 60 cases. The general minimal American Board of Colon and Rectal Surgery requirement of 50 laparoscopic resections seems appropriate. Based on the most recent data, colon and rectal resident experience is tending toward this threshold. Recent general surgery graduate may be lacking the appropriate volume to reach proficiency in laparoscopic colorectal surgery. On the other hand, based on the right or left colectomies, performing more than 10 laparoscopic right colectomies and more than 13 laparoscopic left colectomy provided the vast majority of colorectal residents within the ability to be comfortable with these procedures. But it is important that a concerning number of trainees, 46% of laparoscopic left and 24% of laparoscopic right trainees did not reach this benchmark. It is very important. So how can we solve the problem between fellowships and residence training programs? It's a big dilemma in every center that teach both the residents and fellowships. There's a gap between general surgery and colon and rectal surgery residency training for laparoscopic colorectal surgery. Laparoscopic colorectal surgery is an established safe procedure with demonstrated benefits and proficiency in this specialty correlates within the volume of cases. So general surgery residents are not meeting the volume of cases necessary for them for their proficiency in colorectal surgery. This deficit represents a structural difference in training. Oh, okay. Although the number of advanced laparoscopic cases had increased for general surgery residents, there was still a significant gap in case volume between the average number of laparoscopic colorectal operations performed by graduating general surgery residents, 21, and those performed by graduating colon and rectal surgery residents, 81. Needless to say. Postgraduate or fellowship training in advanced laparoscopic surgery is another means by which faculty or faculty candidates may obtain experience. It's the opinion of SAGES. SAGES maintains that the main goal of such fellowships should be trained future faculty and such programs, and it is important, but such programs should not detract from the experience of surgical residents training in the same institution. One of the best and the most important way to learning surgery to trainees, I think that is the video-based education. Video-based education has potential for use in surgical education. And this method is effective according to the recent literature. A video should be used in addition to step note technique in surgical education. In the simple addition of a brief narrated pre-procedural video to general surgery resident case preparation significantly increased trainee ability to successfully perform a laparoscopic right colectomy. So in the area of shortened hours and less exposure to cases, incorporating a brief but effective instructional video before surgery may improve the learning curve of trainees and ultimately improve safety. And finally, as a prior open experience with a specific operation via ciliatomy or laparotomy can promote mastery of the equivalent laparoscopic procedure, laparoscopic views in dissections, ligation of vessels, and stapling can help trainees to understand the techniques. I have a movie, but I don't know how much time I have to show it. Mohammed, can you help me?
To be honest with you,
I don't have your voice.
Sorry, Dr. Karamati, we cannot hear you. Please unmute yourself.
oh, sorry for that. Thank you, Mahdi. We are running out of time. Sorry for that. And we are going, moving to the next lecture. Before going to the next lecture by Dr. Samsami, Professor Amjad, do you have any comment in this section? I know that you have done a lot to develop, laparoscopic training in many countries, especially in Iran. I know that I have the chance to attend them. What's your opinion on this topic?
Well, I like most of you listening into it. I have experience of training a different level of surgeons, for example. So when you look at resident and you compare them with fellowships, and then you have consultant surgeons, everybody would learn at a different pace, and everybody would require what you call a focus program for their progress. So the magic number in laparoscopy, which is right colon and left colon, it doesn't include rectum. In British data have shown this to be 21 cases, provided you are taught with a very structured approach, right? The problem is that when you have less number of cases and more trainees who wants to be trained, and then there is a pressure from the administration to deliver the service, and everybody wants to do the nice operating. How do you balance that act? So there is a concept which we have written in the past, and which is easy to produce, is called modular training approach, where surgeons do module of the procedure. So everybody has something to do in every operation, and the consultant surgeon makes sure that the case flows without compromising the patient care. And this has been proven in different other specialties, pediatric surgery, urology, colorectal is no different. And we went around the problem. And I would stop here, and we can discuss a bit more on a national level when the discussion starts later on, maybe.
Okay, thank you very much. Thank you. So we can move on to the next lecture by my friend Majid. Dr. Samsami, can you hear me? You can start your presentation. Your voice is off. Please turn it on.
It's okay?
Yeah, it's okay. Thank you.
Hello, everyone. Let me say welcome to all the audiences. and lecturer, especially Professor Amjad. We're talking about a topic that we learned from you. Let me show with my slides, but we have Professor Amjad in this session. Let me talk about my slides very briefly and listen to Professor Amjad's recommendation in this regard.
Sure, thank you very much.
Okay. Good. Okay, our topic is about laparoscopic colorectal surgery for surgical residents and take into account for using laparoscopic surgery in their curriculum. We know that training in laparoscopic resection has shifted from post-residency fellowship to training residency, but the question and debate is that if this supervised surgery affects short-term patient outcome or no, and the laparoscopic colorectal surgery training is associated with several challenges such as patient safety concerns, oncologic outcomes, and steep learning curve of this kind of surgery. There are different kind of articles that one of them is that from Netherlands that they studied from 2010 to 2014 on about 500 patients that they performed laparoscopic colorectal resections in these patients by surgical residents and with supervision. They concluded that there is no difference in time of surgery, in blood loss, and in oncologic outcome. But the conversion rate is higher than in this group of patients that were performed with residents. And they concluded that short-term outcome and patient safety were not adversely affected when the surgery was performed by a supervised resident. And in other articles, they concluded that when supervised and led by an expert laparoscopic surgeon, surgical residents can capable of performing laparoscopic surgery without negative effects on outcomes. And laparoscopic colorectal surgery for residents can improve eye-hand coordination for other surgery, and it can be reproduced and easily incorporated into any surgical residency program. They can look at the videos and they can learn many things from the anatomy repeatedly, and it's one of the benefit of surgery in laparoscopy in comparison with open surgery. If according with my low experience, if I want to recommend about in this regard, I think for starting surgery and starting laparoscopic surgery for residents, we have to start the course with camera holding, and after that starting surgery for benign lesions and elective surgery after about 25 surgeries with lateral dissections for light colectomy, after that lateral dissection for the right colectomy and sublunar dissection. And we have to exclude high-risk groups that they're like obese patients or very thin patients, because this kind of surgery is very hazardous in this kind of patients. And we have to exclude large masses, T3 or T4 tumors, rectal cancers, and high-risk patients. And something that is very important, and Professor Amjad most of them emphasized on it, is that start with standardized approach and continue it. And we have to, and everyone who wants to learn laparoscopic colorectal surgery, be in contact with experts all the time and recheck himself or herself. And finally, you can see here a slide with my colleagues that they're trying to find a splenic flexure and they mobilize the splenic flexure. I think only the surgeon can see something here, and the surgeon has to use his or her finger to release the splenic flexure. It's the same for rectal cancer surgery, but you can compare it with a splenic flexure mobilization here in laparoscopy, that the surgeon is relaxed and all the residents can see the anatomy very well. I asked many residents and friendly actually that what's their idea about the laparoscopic surgery, and most of them emphasize that anatomy is completely different, and they learned anatomy of colectomy or rectal cancer surgery in laparoscopy. And one thing that's very important for them, and I learned it from Professor Amjad and my dear colleague, Dr. Zaman, is that we should save our videos and look at it repeatedly, because the most important thing that we can learn it is looking at our surgeries. We can correct our faults, our mistakes in the next surgery. Thank you for your attention.
Thank you, Dr. Samsoni. Thank you very much. Briefly going to the next presentation. Dr. Ahmadi, are you ready? Can you hear my voice, Dr. Ahmadi? Oh, Dr. Ahmadi, your speaker is off. Yes, it's on off.
Yeah, I'm off.
Thank you, Mohsen. Mohsen is my colleague. And we are so happy to have you here, Mohsen. Yes, you can start.
Okay. Thank you, Dr. Karamati. I'm taking a few minutes of your time talking about integrating the laparoscopic colorectal surgery program into general surgery residence program. As you all know, there's a shift toward laparoscopic surgery in colorectal field, and it has nowadays it has become a routine method of surgery, which has had its advantages, such as better cosmetic results, smaller incisions, shorter hospital stays, and we get all that with almost the same oncologic results as open surgery. And the question is that should we involve the residents in this program as well? Well, we have to consider that the number of open colorectal surgeries are declining, and if we insist on training the residents for open colorectal surgeries, there might not be enough surgeries to train our residents for the colorectal cases. And also the same thing is, we have the same thing in other fields of surgeries as well. We have upper GI surgeries and biliary surgeries, all shifting towards the laparoscopic approaches. So in the end, if we stick to open surgeries, we'll be having certified surgeons with lower standards as before. there are some drawbacks in this case. First is the lack of expertise. A lot of surgeons are concerned that the residents don't have the expertise to accomplish a colorectal laparoscopic surgery. This would lead to longer times in surgery and interoperative complications such as vascular and urethral damage. And the complications might lead to might discourage the residents and lead to a loss of self-confidence in the residents. And also we have another problem in colorectal surgery, which is a steep learning curve, which takes more laparoscopic surgeries to reach the plateau for the training compared to other fields in general surgery. I think we have to start with the basic training for the residents if we want to accomplish a good course for the residents. We can start from the trainer box to make the residents familiar with the instruments, the tools, and the procedures. And then there's the virtual simulations, which the residents complete virtual operation themselves. And then I think they should start with non-colorectal procedures, which have a smaller learning curves and are easier to master, such as appendectomy or cholecystectomy. And after that, we can move the residents to the colorectal surgery program for laparoscopic training. There's also steps in colorectal surgery. We can start with simulations and then move to animal and human cadaver and live animal surgeries. There's also short-term courses which can help familiarize the residents with the procedures. But we should consider that these courses and these steps might be expensive, and the faculties should take into account that this would cost them for the training of the residents. When we want to apply the trainings, in practice, we usually start with camera holding. The residents usually start with the camera, and then they advance into taking part in the procedures. We can have steps for the doing the procedures, such as opening the peritoneal reflection. They can start with opening the peritoneal reflection and then move to dissection of the meso and exploring the urethra and major vessels, and in the end, vascular clipping and resection and anastomosis. The thing that we believe is that it's not necessary for a resident to complete all the tasks in one surgery, and it can be done in multiple surgeries, so that the problem of the longer time of surgery would be solved by this matter. If the resident does different procedures in different surgeries, the time of surgery might be far less than if the resident does this procedure in one surgery. If I want to sum it up, I think the residency program should have a laparoscopic colorectal training curriculum for the residents, and the gap between the open surgery and the laparoscopic surgery can be bridged with simulation, cadaver, and animal surgery courses. And in the end, the cost of training each residence must be taken into account. And I think in the most important thing is that we should encourage the residents to take part in laparoscopic surgeries. Thank you for your attention.
Thank you, Mohsen. Thank you very much. Nice presentation. The next presentation, Dr. Zamani, do you have any presentation on any slides?
I would say hello to everybody, and yeah, hi.
Nice.
I would say hello to everybody, and thank you for your invitation this webinar. And me and Professor Amjad have a PowerPoint presentation for the training, because when we started with Amjad in Iran, I have tried to be as a honored mentorship of him, and after it, we have some session in my country. As you know, that Amjad is coming, and we have some master class and some live surgeries we have. And after it, we have one course of fellowship in the Serbia, as Amjad say. Thank you. Please, Amjad.
Thank you very much. I'm so happy to hear presentation with Professor Amjad. Yes, Professor Amjad, please.
So Hamid, if you have slides, you can start and I'll just comment. Or if you want me to show slide, it doesn't really matter. If you have something to show, if you haven't.
I'm not sure, but I'm check.
Okay, while you're checking, I can just show them if I have something.
Yeah, thank you.
No problem. And let's see if I can find some training program. So I think there are lots of slides, but I'll just sort of, I don't know, you should be able to see this now, I hope. Are you able to see it?
Yeah, we can see your desktop now. Oh, yeah, training of surgical workforce. That's great. Thank you.
Right, okay. So this is really, these are some slides and some work I was asked to sort of give, and I would just sort of go through some of this. We don't have to sort of listen into all of this, because I wanted to make it like an interactive discussion between colleagues. So that's why if I just sort of go up here and play it now, that's okay. Yeah, this is better. So currently, as this is for people who obviously don't know me, I started in Portsmouth many years ago as a consultant. Some of you have actually come to Portsmouth when I was there in mid 2000s. So very nice place. Then I moved to Shimpalamo, which I'm currently working as well. And I'm actually not far from you now. You know, I'm just across the water. I come to Doha and almost can see the lights of Shiraz, you know, across the water. So Iran is not far from where I am. So really the outline is this, that how do you train people in colorectal surgery? And I like to sort of, with few slides and mostly by discussion, share with you of how people get trained. How do people learn? And it's more of my observation in my journey of being a teacher, rather than putting any science behind it. And I use minimally invasive surgery as a model. You know, learning is in general and model is laparoscopy. And then I speak to you about how to set it up on an institutional level. I saw Samsami and And my other colleagues, Majid, he gave a very nice presentation along residency. And then I sort of used Pakistan-based training model because I was asked to give this talk to my medical school. You know, I left Pakistan nearly 25 years ago, and they seem to think that I owe a lot to them. So I have to come back and train them too. So does this matter? That's the key. You know, my open surgical colleagues always tell me that my scars are slightly bigger than yours. What's the big deal? You know, this is not such a big deal. We know this is a big deal when people have problem with these big scars. You know, when they have incisional hernias, wound infection, they stay in hospital longer. There is a problem. This is a picture of two guys in Memorial Sloan Kettering, just opposite to each other. And they both had liver surgery done. One had a recipient liver or liver transplant, other one had a donor, live liver donor hepatectomy. And you could see the difference between the two on day one or day two, or whenever they want to take it. Now, the real question is this, that why should we train people? You know, why should I go around the world and take a pain to train everybody? People that I've never seen before, people that I'm not going to see, perhaps after the training masterclass. What is in this for me? So the bottom line is that this is a very selfish trait in the end of Homo sapien, you know, which we all are. We want to leave a legacy behind. We also want to make sure that the progress is guaranteed if I transfer whatever I have learned from the previous generation to the next generation. So this is the whole gist of it. We are doing this as a selfish trait. You know, I'm often asked, why you go around and train people? I say I do it because one day when I would need an operation in Iran, I would have enough trainees who I know would look after me. Or if I go in Pakistan and need an operation, I would have enough fellows who have trained. So it's a selfish way, really, if you think about it. We have looked into this. This is Danilo Miskovic. He published this paper when he was in Portsmouth with me at the time. If people are trained appropriately, then their outcomes are very similar to people who are expert. This is no science. Everybody knows this. And everybody says, well, it's very easy. You know, you do a new procedure. TATME was a lecture. We saw that before. Robotic surgery is a new thing and laparoscopy is a new thing. And you say, well, you do enough of this and then we look at the outcome and then we will know if it works or not. The problem with this approach is that by that stage, the damage is already done. You know, if my TATME have created 11% multifocal local recurrence in a national level study, I have already created a big problem. And now I have come to the conclusion that perhaps I should learn it properly. This is a wrong way of looking at it. So I generally think surgery is a very peculiar specialty. Why we are a peculiar specialty? Because it's a peculiar group of people. It's a craft specialty. You know, you can only learn so much of theory unless I do it with my hands. And if I do it over and over and over again, only then I would become either good at it or bad at it, depending upon who's teaching me. I genuinely believe that standardizing the operative technique and making the operation look boringly similar all the time makes it easier to learn for the trainees. How do people learn? You know, this is not a new slide. This is a slide which has been around. And if you look at it, that me giving a lecture, very little passive learning. You know, people listen into it, they'll forget very, very quickly. You can read, you can do it. But if you think about it, when you have participatory teaching methods, you know, when people interact with each other, when they look at the videos, when they revise what they are looking at audiovisually, they learn faster than others. And I think that's the key to remember. How do we retain what we have learned? It's by repetition. You know, if you think about it, I have seen this all across the world when I go and teach people. When surgeons are familiar with what they are looking on the screen, their hands move faster, their hands move purposefully, and the operation progresses purposefully. When they are looking at the image, which they don't recognize, which they have never seen before, then they do movements that doesn't progress the operation, or they do abrupt movement to create a mistake. So pattern is the key. When I want to learn something, I want to be shown this pattern over and over and over again the same way. And then I have to reproduce it. You know, Majid Samsami said something about recording. When you record your operation, you double the exposure. Once you're operating, then you bring it back and you see it unedited. So you remember that pattern more and more. Second repetition, you could see. Third and fourth repetition. This is not a new science. You know, this is how all of us have learned, not just laparoscopy, most things in life. This is our work from Portsmouth. When we looked at 4 of our residents, I call them resident. In England, they are known as specialist registrars. They were senior guys, 4th year, 5th year resident, who were doing part of the operation as a modular approach. So they would do module 1, or other guy or girl would do module 2, and then I would do module 3. So the operation progress, everybody learn, and they do that. So break the operation down into modules. This is the data for that year when we looked at it. This is Portsmouth HST's higher surgical trainees. Total of 104 cases were done by 4 of these guys. 3% conversion rate in that data. They were all supervised. They didn't do anything themselves. Lymph node yield, 14 median lymph node, 99% R0 resection rate. Morbidity, length of stay is as you would expect. At the same time, I was training senior surgeons, you know, people who are established consultants from around England. They were coming to learn in national training program because everybody thought this is a young man's game. Old people cannot learn this. The median age of NTP, National Training Program trainees, was 53 years, while the HST median age was 32 years. So there is a big difference between the age. In the same year, they did 102 cases with me. You could see very, very similar outcome between both groups because the common denominator was the person who was training both groups and the technique that I was using to train the groups at the same time. Everybody said, well, that's very well because, you know, they are with you, you tell them cut here, they do it, it all looks very good. How good they would be when they go into independent practice. So 4 of them became consultant in different part of England, and I asked them to give me their first year data. This is their first year collective data of their independent practice as a consultant. Very, very similar outcome as compared to what they were doing it with me. So when Majid and Mahdi and everybody else was presenting the problem the resident can have, either operative time is more, conversion is more, or the outcome are worse. In my case, my trainees did better than me. So that is no surprise at all. So in conclusion, it was easier for me to sort of come to this conclusion that idea is to produce more of the same. I'll sort of go past this. This is really sort of looking at NTP program. We have set up similar program in different parts of the world, and they have behaved very, very similarly. So this is just the data from LabServe. Hamid Zamani is one of the faculty member who's involved in training Serbian surgeons. And I'm very grateful for him that he finds time before Corona to travel and to help me with the training. I hope that he will be vaccinated soon and then he can travel. So this is 2 programs run side by side now. This is Lab Colorus, which is a Russian program, and then the Serbian program run in Belgrade. The idea really is what I call hub and spoke model. So you pick the faculty training centers, 6 to 8 main centers where you would train people to become trainers so they can train the districts. So you could see that there were 32 hospitals in the whole of the country. And once we trained 8 trainers, they are training it. I don't go and train every district surgeon in Serbia, but I made sure that, you know, we have the standard and people learn from us in a similar way in those 6 training centers. This is some in-house workshops. You know, this is going back. As you would see, Ayhan Kuzu is also another faculty member. I'm grateful to him. He often comes and accompanies me doing these master classes or modular training. It's about team building. It's not just building the surgeon. It's not about, you know, you start saying I can teach Raza Karamati and, you know, his anesthetist would be against him, his resident would be against him. You make sure that you train everybody. So everybody have a stake in this. This is important as well. And once they have done that, this was a diploma-based University of Belgrade gave them diploma after they completed the program. So this was a university-based program, Ministry of Health-backed program, something perhaps which Iran can easily adapt. You know, TUMS is a Tehran University of Medical Sciences is a very reputable university. If they want to take this on, this is already done. This is already there for people to copy and paste the model. So in Pakistan, no dissimilar thing. Everybody wants to learn. But when you go and you teach them, they're all very keen, but there is no structure to it. When you ask them that, okay, you learn, you collect data, you learn with a purpose, and you teach others. Most of us want to learn so that we can practice ourselves. Very few of them want to learn so that we can teach others. That's the problem. I think that's the real crux of the training. These are centers around the country that over the last sort of 14, 15 years, I have been involved in teaching and training and made friends. And these are the guys who are doing this. This is Karachi. They have a robot system as well. So we teach them robotic surgery, laparoscopy. They're all very young and keen, and old people also come into theater. Some of the guys who are very senior, they all want to come and they want to see. So the culture is there to learn. The real idea is the retention and their ability to reproduce. That's what is lacking. You know, people want to learn this and then they get occupied in day-to-day life. That's why I'm very keen that some specialized centers should take responsibility to train their districts. Otherwise, everybody wait for the next year when you come. It's a difficult journey. You know, this is some of the pictures which my residents or fellows have taken with me who travel with me. When you miss the bus connection from one city, or when there is a strike of aeroplane, you know, and you have to sleep in the middle of the night. It's very difficult to explain this to my wife. You know, what is in this for me? Why I have to be away from home in December holidays? You really got to do this if you really want to bring the change and if you really are committed to it. And it's a two-way thing. It is not only just the trainer, it's the trainee who need to have the same culture and same sort of mindset. I genuinely think that there has to be an ownership, you know, call it Iranian Council of Surgeons or Royal College of Surgeons as we have, call it Tehran University of Medical Sciences, I don't know. You know, somebody have to take the ownership of the training program. Ministry of Health, for example. You need dedicated group of surgeons who genuinely are interested in developing this and delivering it. Now, you need to have one person leading the program with the idea that this would involve everybody's success. And then you need to have connection and a support of key stakeholders, which is industry in our case, or Ministry of Health as it were. So I would stop here really. I just wanted to give you a flavor of that. You know, I had lots of data slides comparing Russian outcome, Serbian outcome, and Iranian surgical outcome, which Hamid Zamani very kindly shared his data with me many, many years ago. And to no surprise, some of the data from Iran is much better than British data. So the learning doesn't recognize any culture, languages, beliefs, faith. We are very, very similar. We all learn at the same pace if we are committed. So I'll stop here and I would open this up for discussion for other people really. Thank you.
Thank you, Professor Amjad. It was a great talk. To be honest, we will be so happy with your help to arrange such a, training courses for the whole country, for the whole surgeons in Iran. Yeah, thank you very much for doing this. And we need to work on it and think of it more than this, and to design the courses for the whole country. Thank you very much. Any question or comments from the others? Dr. Zamani?
If Professor Amjad let me, I explain more about the modular training program, because it's a very important thing and very important schedule for the training that sometimes we have not enough aware about it. Okay. So I would I can go to the
share screen.
Yeah,
Because you want to share
because I couldn't show the PowerPoints yet. I would go to the, but I couldn't find it out. So yes, sorry.
Yes.
Can you see?
Yes. Yes, we can.
Yes, we can.
Yeah, it's the it's sometimes about the modular training in laparoscopic colorectal surgery that it's maybe can involve everybody in the operation. I mean the resident and flowship as well, and the one surgeon can supervise on the steps, and then they could change the position of the modular training. Each procedure of the colorectal surgery can broken down in the number of the modules, and it's some segments that we can determine for some surgeon as a cameraman, and then somebody then they performed the operation and somebody assisted him. And it's can make more focus on the part of the operation by some surgeon, and then you can divide it, for example, some smaller part of the surgery for the some less experienced surgeon like the resident, and some more important segment of the surgery to the one flowship as a more experienced surgeon. Like this, because it's the modular training of the right hemicolectomy, for example. For example, the patient setup, port placement, managing the small bowel, exposure, vascular pedicle, and medial to lateral dissection. Each part of the operation and peri-operation is not a simple part, but we can divide it this part of the surgery to the simple part and more complicated. For example, for 2 months, we can start it with the module 1 for the resident, and then module 2 for the flowship, and then change the position, because the module 2, it's the subileal dissection for right hemicolectomy, lateral mobilization, hepatic flexure management, and the right branch of middle colic, extraction and anastomosis. Each part is accomplished by 2 surgeons, but the surgeon that is responsible for one part is the main surgeon. So, for example, the modular training for left hemicolectomy, as I said about the right, the module 1 is the patient setup, port placement, managing a small bowel like that, exposure, vascular pedicle, medial to lateral dissection. And module 2 is the lateral mobilization, splenic flexure, mesenteric division, cross stapling, bowel, and extraction and anastomosis. For example, some part like the lateral mobilization of right and left, we can put this part of the surgery to the field of the one resident that is started very soon. And it's the case that in the modular training can provide. So the problem is for the center, I think. It's when some patients coming to my center, each surgery I can do this because I am the colorectal surgeon. But for example, sometimes some pelvic dissection like the TME or partial TME, or some type of surgery like the transverse colon surgery, as Amjad said. It's the second or last part of the experience of the colorectal laparoscopic surgery that is not put in the first experience of the surgeon. And it's why that the team can determine that which operation can perform by which surgeon. And it's the key that the training course is completed. Thank you.
Thank you, Professor Zamani. Thank you. As we are running out of time, so we can close webinar now. Professor Amjad, do you have any other comments or?
No, I'll just finish off by first thanking all of you. And like I said, I share my excitement and joy just by seeing you and seeing you well, you know, and that's what we wish. We wish to be outside of this nasty pandemic, so at least we can physically see each other. I'm very pleased that even in this difficult time, you know, you have taken the pain to organize teaching and training for people who are interested in this. So my heartiest congratulations for that. Most important thing is that the very fact that you are talking about training, the very fact that you are you know, discussing this, that then you are interested in this. And this is something that we all have to invest for our future. You know, not far from here, where some of us certainly are, we might be needing a good oncological operation. So we make sure that we have trained the next generation of surgeons who can do this on us. So I'm pleased to see you all. I remain open and I remain very committed to training. You know, Iran is very close to my heart. I have a lot of friends. Some people have become more than friends for years. And I'd be very happy to help any way I can, you know, for the years to come. So, you know, thank you once again. Thank you.
Thank you, Professor. We are so happy. And thank you very much for your time. I know that you are very busy. And if there is no comment from the other speakers, no comments? Okay. I'd like to say thanks to all speakers for their outstanding presentations, and also for the audience for their good comments and also the questions. We had a large number of thank you message in the chat room. Thank you all, and I wish you all the best. I just want to say you all that we are going to take a photo, you know, online photo, you know, the software. So I will be happy if everybody turns the camera on and we can take a photo all together. Great, 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 great. Great. Miss Sadeghi is our host now, and can you hear my voice?
Yes, doctor, I can hear,
Okay.
and I'm taking a lot of pictures.
As you mentioned, we are ready for the photos. Some of our colleagues are, you know, didn't open the cameras anyway, so a large number of them are ready. I can see Professor Fazeli. Professor Fazeli, we are going to take a picture.
All the participants, it is appreciated if you can turn on your videos.
Yeah. We are ready.
Yes, I take a lot of photos.
Great. Good. To be honest, it's the first time that I'm taking an online photo. So for me, it's very interesting. I didn't have this experience before.
That's it.
Good.
Thank you all.
Oh, thank you very much. Thank you very much. Again,
Thank you, Dr. Karamati.
Oh yeah, we are welcome. Thank you, Professor Keshwari.
Thank you.
Thank you all.
Thank you all. Goodbye.
Thank you, everybody.
Nice day.
Goodbye.
Goodbye. Goodbye.